off and then state your name and the organization that you're representing. We'll begin with Allegheny County.
It's Captain Dan Lasher, Allegheny County Detention Center.
Great, welcome. Anyone else from Allegheny?
Becky Myers, Allegheny County Health Department.
Great, hi Becky.
Hi.
Anyone else from Allegheny?
Hi, Rose Lehman, Allegheny County LBHA.
Great. If Allegheny is done, then we'll move on to Anne Arundel. Anyone from Anne Arundel? Okay, we'll move on to Baltimore County.
Good morning. Renard Brooks, Deputy Director, Baltimore County Department of Corrections.
Good morning. Is there anyone else from Baltimore County?
Yes, hi, good morning. This is Stephanie House. I'm with the Bureau of Behavioral Health, which is the local behavioral health authority for Baltimore County.
Great, thank you, Stephanie.
Good morning, Marianne. I'm not sure if you're looking for providers, but Howard Ashkin is here, and we have OTPs in Baltimore County, and I'm also here for Maytime.
Great.
Thank you for the invite.
Absolutely, thanks for joining us.
Good morning. My apologies. This is John Kelson from Anne Arundel County. I was on mute. Jennifer Road Detention Center.
Great, thank you. Anyone else from Baltimore County? Hearing none, then we'll move on to Baltimore City.
Hi, Marianne. It's Vicki Walters representing Maytodd and also a provider in Baltimore City. Thank you.
Thanks, Vicki. Anyone else from the city? If not, we'll move on to Calvert County.
Yeah, Major TD Reese from Calvert County Detention Center.
Good morning. Thanks for joining.
Good morning.
Anyone else from Calvert? Okay, Caroline County.
It's Warden Charles Scott, Caroline County Detention Center.
Good morning.
Lisa Flaherty, Caroline County.
Thanks, Lisa. Carroll County.
Hi, good morning. Marie Litta, Carroll County OBHA.
Good morning.
Good morning. Veronica Dietz, Director of Crisis Services at the Carroll County Health Department, LBHA.
Good morning, Veronica. Anyone else from Carroll? Okay, we'll move on to Cecil County.
Good morning, Marianne. Mike Masuli from the Cecil County Health Department.
Hey, Mike.
It's Mary Allen, the warden from the Cecil County Detention Center.
Good morning.
Lieutenant Jolly, Administrative Commander.
Good morning. Anyone else from
Good
Cecil?
morning.
Okay, Charles County. If there's no one from Charles County, we'll move on to Dorchester County.
Jay Hughes, Dorchester County Director, Dorchester County Department of Corrections.
Great. Anyone else? If not, we'll move to Frederick.
Hi, Sarah Drennan with Frederick County Health Department, the local behavioral health authority.
Good morning, Sarah.
This is Jessica Chowski with the County Health Department, local behavioral health authority as well.
Good morning.
Again, Melissa Greenwell with the Frederick County Health Department, and I also work in the Frederick County Adult Detention Center.
Great, thank you. Garrett County.
Captain Jim Titchell, Administrator of the Garrett County Detention Center.
Okay. I am getting a little bit of feedback, so if you are not speaking, if you could just please mute yourself, that would be great. Okay. Harford County.
Good morning, Sean Martin, Harford County Health Department, Local Addictions Authority.
Good morning.
We're trying to get on.
Okay.
Can you hear us?
Yes.
Okay. So we missed kind of, I heard Howard County. Are we doing introductions? I apologize.
Yes, we are. You guys are up next. So just one second. We're finishing up Harford County introductions. Is there anyone else from Harford County on the line? If not, then Chris, go ahead and introduce yourself. Howard County.
Oh, you want to start?
What? We're starting?
Yep, go ahead again.
Oh, okay. I thought we were later on the agenda.
So at this point, we're just stating names and then saying the organization that you represent. We're just doing introductions.
So my name is Chris Collins. I work for the Howard County Health Department, and I supervise the treatment services within the Howard County Detention Center.
Great.
And I'm Andrea King-Wessels, and I'm the deputy director. Right now, I'm acting director at Howard County Detention Center.
Great. Good morning. And I know there are a few others on the board.
Hi, Ro Rogers, Bonacorsi, Director of the Bureau of Behavioral Health, Howard County Health Department, LBHA for Howard County.
Thanks, Ro.
Good morning, Shireen Bentley. I'm the Deputy Director for the Bureau of Behavioral Health, Howard County Health Department.
Great. Good morning, Shireen.
Good morning.
Is there anyone else from Howard County on the line? Okay, then we'll move to Kent County. Hearing no one from Kent, we'll move to Montgomery County.
Good morning. This is Hardy Bennett.
We have somebody on here from Kent. I'm Warden Herb Dennis from Kent County Detention Center.
Good morning.
Good morning again. This is Hardy Bennett of Health and Human Services for Montgomery County.
Good morning.
Good morning. This is Samar Cleave, Quality Assurance Manager from the local Behavioral Health Authority. And I actually have a request. Is it possible to attach to the agenda because I cannot open it to the chat?
Sure. Let me see if we can.
Thank you.
Yes. I can send it to you in a different format because I can't share it right now.
Thank you.
Sure.
Good morning. This is Erin Thatcher with Montgomery County LBHA.
Good morning.
And also, good morning. We still had two from Kent. It was Kent, Captain Wicks for Chief Security, and also
Captain Steve Wallace. Good morning, Administrative Captain, Kent County Detention Center.
Good morning. Thanks for joining.
Good morning. This is Kate Beckley from Montgomery County Government. I'm with Management Services Division.
Good morning. This is Robin Cody. I'm the Chief of Medical and Behavioral Health Services for the Montgomery County Department of Correction and Rehabilitation.
Good morning.
Good morning.
Great. Is there anyone else from Montgomery County on the line?
Good morning.
Yes.
Good morning.
This is
My
Susie
name's Larry Stewart. I'm sorry, Angela, go ahead.
Okay. Good morning. Angela Talley, Director, Department of Correction and Rehabilitation.
Great.
And last but not least, my name is Larry Stewart, Manager 3, Treatment Services, Health and Human Services, MAT.
Great.
And this is Susie Malagary, Warden, Montgomery County.
And one more, Athena Morrow with Behavioral Health and Crisis Services.
Adam Jones with the local Behavioral Health Authority.
Okay, you guys are well represented this morning. Great. Anyone else from Montgomery before moving on to Prince George's? Okay, if not, then Prince George's County.
Good morning. This is Sky Merritt, Acting Deputy Director for Department of Corrections.
Good morning. This is Director Corinne LeBay with Prince George's County Department of Corrections.
Good morning. This is Gregory Bearstop. I'm the Acting Chief of Inmate Services at the Prince George's County Department of Corrections.
Good morning.
Good morning. This is Tracy Boucher from the Prince George's County Local Behavioral Health Authority.
Thanks.
Good morning. This is Lavana Walker, Department of Corrections, Budget Analyst.
Good morning. Is there anyone
Good
else?
morning. This is
Sorry.
good morning. This is Dr. Metzke from Prince George Medical Unit.
Great. Good morning.
Good morning. This is Patricia Stevens
Program Director for Victim Services, DOC.
Good morning. Anyone else?
Hey, Susie. Can you hear me? Yes.
Okay, next up we have Queen Anne's County. Is there anyone from Queen Anne's County on the line? Okay, hearing nothing, then I'll move on to St. Mary's County.
Hi, it's Mary Ann Thompson. I'm the Deputy Warden at the St. Mary's County Detention and Rehabilitation Center.
Good morning.
Hi, and I'm Tammy Lowy. I'm with St. Mary's County Health Department, Behavioral Health Division Director. We're also the LBHA.
Thanks, Tammy. Is there anyone else from St. Mary's? If not, we'll move to Somerset. If no one from Somerset is on the line, then we'll move to Talbot County.
Yes, good morning. This is Corey Pack, Talbot County Council, also chairperson of the JRA Local Government Commission.
Good morning.
Good morning. This is Belinda Frankel from the Midshore 5-County Core Service Agency and the Forensic Mental Health Worker.
Great. Thanks, Belinda. Okay, we'll move on to Washington County.
Sandra Feliciano, Senior ACOM, Office of Inmate Health, Department of Corrections.
Great. Anyone else from Washington?
Major Craig Rowe, Warden of the Washington County Detention Center.
Great. Thanks for joining.
Mm-hmm.
All right, we have 2 counties to go. Next up is Wicomico County.
Michelle Hardy from the Local Behavioral Health Authority.
Thanks, Michelle. Is there anyone else from Wicomico on the line?
Yeah, good morning. Jessica Taylor, Wicomico County Local Behavioral Health Authority.
Thank you. Okay, if there's no one else from Wicomico, then we'll move to Worcester. Okay, did I miss any county representatives?
Hi, this is Yvonne Harris from Somerset County Health Department.
Great, thanks, Yvonne.
Good morning. This is Lisa Welch. I'm the state's attorney in Garrett County, chair of the County Drug-Free Communities Coalition, and the county representative to the JRA.
Great, thank you.
Good morning. This is Christina Donnelly. I'm with the Office of the Deputy Secretary for Operations, Department of Public Safety and Correctional Services.
Hello, good morning. This is Neil Woodson with Division of Parole and Probation, Department of Public Safety and Correctional Services, Assistant Director.
Thank you.
Good morning, Latanya Stallworth, Department of Public Safety and Correctional Services, Division of Parole and Probation.
Good morning, Latanya.
Good morning. This is James Flood Jr., Assistant Warden, Baltimore Central Booking Intake Center.
Good morning, Dolores Stoller Rolette, DPSCS.
Thank you. Okay.
Good morning, this is Kathy Murray from the Cumberland Treatment Center in Allegheny County.
Good morning. Okay. Anyone else before we move on to our opening remarks?
Good morning, my name is Brian Polk. I'm from Wicomico County Health Department.
Thanks, Brian. Okay, well, thank you everyone for taking the time to introduce yourselves. We have a great group on the line. So now we're going to move on to just opening remarks from our state leaders who are very committed to advancing this work. And first up, we have Glenn Fuston, who is the Executive Director for the Governor's Office of Crime Prevention, Youth and Victim Services. So I will turn it over to Glenn.
Great, thanks, Marianne. Just starting off, I don't know if you guys have ever been in that position where you come into a big meeting, you're not exactly sure how it's going to go, but then you see Marianne's face and you know it's going to go so smoothly. So I just want to thank you for taking the lead there and driving it forward, and for what you and our office and BHA have done to organize this meeting. It's a great pleasure to be here. As Marianne said, my name's Glenn Fuston. I'm the Executive Director of the Governor's Office of Crime Prevention, Youth and Victim Services, or Legacy GOCAP, since no one likes our new acronym, but we go with it. I wanted to first say it's a pleasure to be here, as I already said, and joining Executive Director Steve Hsu from the Opioid Operational Command Center and Dr. Jones, the Deputy Secretary from Behavioral Health Administration. You know, I hope that everybody is aware of what our office's drive is, and it's utilizing a multidisciplinary approach to reduce crime and address the needs of the people in the communities that we serve. This includes those living with substance use and behavioral health disorders. And I think that we're all aware that someone who's incarcerated with an opioid use disorder is at a high risk of overdose in the time after they're released from incarceration. And our hope and our intent behind this law is that we start treatment while they're incarcerated and then emphasize the continuity of treatment upon their release, and that we can provide them with the necessary support to lead productive lives once they are released and divert them away from the activities and the environments that may have contributed to their incarceration in the first place. Taking a proactive approach to reducing this risk of recidivism is pivotal to reducing crime in Maryland. And we look forward to the opportunity to support efforts to provide medication-assisted treatment to those who are incarcerated through implementation of the opioid use disorder examinations and treatment in local correctional facilities. Our office will evaluate the implementation of this to ensure that medication-assisted treatments are in place in each jurisdiction, and will measure the impact of those programs overall. We're certainly still looking for 6 jurisdictions to join the efforts of St. Mary's, Howard, Prince George's, and Montgomery counties who have already implemented these programs. And our goal is to have this in all detention centers by January of 2023. So I know that this will be a very insightful meeting, a very helpful meeting to help bring this forward. If there's anything our office can do to support this effort, please make sure you reach out. So thank you very much. I'll turn it back over to Marianne.
Thank you, Glenn. Next up to give remarks is Dr. Aaliyah Jones, Deputy Secretary for the Behavioral Health Administration.
Good morning, and thank all of you for joining us for this virtual meeting that will help facilitate the next steps in the implementation under HB116. We are honored to partner with the Governor's Office of Crime Prevention, Youth and Victim Services, the Department of Public Safety and Correctional Services, the Opioid Operational Command Center, our local behavioral health authorities, the local detention centers, and many, many others on this legislation, and are glad that you all have assembled today for this learning collaborative. As you all know, the legislation passed in the 2019 legislative session, and among for substance use disorders and ultimately offer all 3 FDA-approved evidence-based and life-saving treatment medications to treat opioid use disorders in inmates by 2023, a policy and practice that is endorsed by numerous national organizations, including the American Society of Addiction Medicine, the National Council for Behavioral Health, and the World Health Organization. According to the American Society of Addiction Medicine, nearly 20% of people in America's jails and state prison systems have regularly used heroin or opioids prior to incarceration. Given the historical problem with opioids that we've had in the state of Maryland, most recently gaining steam under what's labeled as our current opioid epidemic, this percentage is certainly higher, likely higher in our state. This disease of opioid use disorder is largely untreated in most correctional settings across the country, and the state of Maryland has accepted that this is not in the best interest of those who have these disorders, to the incarcerating facilities, nor to the state, as missing the opportunity to treat this condition fuels overdoses in jails and prisons, increases risk of violence to corrections personnel, disrupts medical care for people who were in treatment for an opioid use disorder prior to arrest, contributes to overdose and risky health behaviors in the community upon release, and historically recidivism due to substance use disorder motivated criminal behaviors, which resume when many people return to the community and return to substance use. This collaboration will enable us to increase the number of individuals accessing and staying engaged in needed behavioral health services while incarcerated and upon their release, which will give them a better opportunity for success in the community and help prevent overdose, a leading and preventable cause of death among formerly incarcerated individuals. Without treatment with medications for opioid use disorders, there is a 10 to 40 times higher risk of death from overdose within 2 weeks of release from prison in a 2018 study. The Behavioral Health Administration is fortunate to be able to provide funding for implementation of this legislation through the State Opioid Response Grant, awarding an aggregated total of $1.7 million in funds to the initial 4 detention centers, with a total budgeted funding for jail-based medication-assisted treatment programs of $2.8 million. A total of 4 detention centers that have already been mentioned volunteered to pilot the program by January 2020. And originally we had planned on adding another 6 jails by January 2021, with the planned adoption for all sites by January 2023. Like most things, we've had a delay in adding more sites due to COVID, limiting our presence to only the 4 original locations. However, it is our hope that as we transition through this pandemic and return to whatever the new normal will be, that those facilities that have not adopted this approach will move forward expeditiously with the information and supports that you need. Hence, we have invited local behavioral health administration directors and detention center wardens to share their challenges and successes as they have planned to provide medication-assisted treatment and implemented these plans. By January 2023, it's expected that every local detention center will offer all 3 federally approved medication-assisted treatments, buprenorphine, methadone, and naltrexone, to persons within their institutions with an opioid use disorder and at time of release. That's a really big deal. We know that providing addiction treatment in correctional settings is not without its challenges, and those challenges may vary by facility or environment. And so again, we're grateful today that jurisdictions who are operating under HB116 are going to be sharing their experiences, their program strengths, challenges, suggestions, and some recommendations to make adoption run more smoothly for jurisdictions that will be adding these services in the coming years. We would like to express our appreciation to the counties that have implemented this legislation, because the treatment of opioid use disorders in these settings is a critical public health and ethical issue. What you all are doing is changing our historical culture of complacency and disregard of persons within the criminal justice involvement in the criminal justice system who have opioid use disorders. You're communicating that the healthcare system and criminal justice system appreciate the humanity and dis-ease of those with opioid use disorders behind the walls, and that together we are here to help people who often feel forgotten and cast aside. We are helped to partner to save lives and to give people a fighting chance to live out their hopes and dreams upon release to the community. We look forward to the day when access to evidence-based opioid use disorder treatment, including all FDA-approved medications, is the standard of care for all detainees or incarcerated individuals across the country. And in the meantime, we are grateful that the state of Maryland will set a positive example and model for the nation as one of few states in the country providing such comprehensive access to these effective treatments. I look forward to this shared learning opportunity and meeting this gap in service with all of you. Thank you.
Thank you, Dr. Jones. And next we have Steve Hsu, the Executive Director for the Opioid Operational Command Center.
Good morning, everyone. And thank you, Dr. Jones and Director Houston, for your terrific opening remarks. I'm delighted to see so many of you this morning. I think we may have set a record for roll call. That was quite a march through. And I'm also delighted to be here as part of the HB116 Opioid Screening and Treatment Learning Collaborative. This is so important. I'd like to thank the Governor's Office of Crime Prevention, Youth and Victim Services, that's Glenn Houston's operation, and the Behavioral Health Administration, that's Dr. Jones's operation, for their support in helping to organize this event. As you know, HB116 was passed by the Maryland General Assembly and signed by Governor Hogan back in 2019. This law requires all local detention centers to provide substance use disorder assessments, counseling, and to offer all 3 FDA-approved medications to any inmate who requests SUD services by the year 2023. the OOCC wholeheartedly supports the goals of this legislation, as we know that individuals with an opioid use disorder who are incarcerated are at very high risk of overdose upon release from a detention center. There has been a lot of research in this area, as many of you probably know. The research indicates that approximately 2/3 of the U.S. prison population has an active substance use disorder, with an additional 20% being under the influence of drugs or alcohol at the time of arrest, although they may not meet the diagnostic criteria for a substance use disorder. These percentages highlight the need to offer a comprehensive array of screening and treatment services to individuals who are incarcerated. We also recognize that providing substance use treatment and medications to treat opioid use disorder in detention centers is a heavy lift that will require a lot of planning and great partnerships, and that's what today's all about. That's why we're so glad that you're here to learn more about how to expand services in local detention centers and to improve facilitated reentry into the community. We've got a great lineup of presenters. I want to thank the teammates who pulled all these speakers together to talk about the need for expanding services for individuals who are justice involved and about best practices for achieving the goals outlined in the legislation. We're especially excited to hear from the 4 jurisdictions who implemented the requirements of the law over the past year. I'm sure they have lots to share. We're hopeful that going through expanding targeted services to individuals who are justice involved, we will have a positive impact on reducing opioid overdose and ultimately opioid-related mortality, which is so important, as we all know how things have been trending in the past year as a result of COVID. So thanks again for your support and for everything that you do. We're looking forward to continuing our work with all of you. And please don't forget that you can always reach out to us at help.oocc@maryland.gov. That concludes my remarks. Back to you, Mary Ann.
Thank you, Steve, and thank you, Glenn and Dr. Jones. So before we move on to the sharing amongst the 4 jurisdictions who implemented, we have 3 really great presentations. Our first presentation is from Dr. Brendan Salinger, Associate Professor in the Department of Health Policy and Management at the Johns Hopkins Bloomberg School of Public Health, and he'll be discussing risk factors for overdose for individuals who are justice involved. So I will turn it over to Brendan at this time.
Thanks so much. Do you want me to share slides, or would you like to share from your end?
We'll pull them up. Thank you.
Great. Well, while we're waiting for that, I just want to thank you all for the invitation today. I am so delighted to be here with this group, and I'm going to try to not make this too wonky. I'm going to try to leave a couple minutes for your questions, but I'm going to just dive right in. And next slide, please. Just as a disclaimer, the work that I'm going to be describing comes from a grant funded by the U.S. Department of Justice, Bureau of Justice. I really thank the funder for supporting this work. And I want to just emphasize that the findings and conclusions that I share with you represent my own perspective and not necessarily anyone from the state, including BHA or any other state agency or the U.S. Department of Justice. Next slide, please. So as I said, this was a Harold Rogers PDMP grant from DOJ that ran from 2015 to 2019. It was a partnership between BHA, CRISP, which is the Health Information Exchange here in Maryland. They're a really top of the class, kind of nationally recognized entity for doing data-related work, and the Johns Hopkins Center for Population Health IT. And the aims of this grant were to perform data linkage across a variety of different state data systems in order to assess the feasibility and utility, basically what could we learn from developing algorithms to predict opioid overdose. They're starting with the prescription drug monitoring program, but linking to other statewide databases. And I think really important to know, Maryland was really one of the national leaders in this. Massachusetts, I would say, is really our only other peer state. So I want to just highlight the leadership of Maryland in this area. Next slide, please. So ultimately, through this partnership, we were able to identify actually histories for more than 2 million Marylanders. So people who appeared in any of these databases between 2014 and 2016. So people who received controlled substance prescriptions from the Prescription Drug Monitoring Program, people who encountered hospitals in Maryland, people who interacted with the specialty behavioral health system. Sometimes we call, at that time it was Beacon, I think now it's Optum. Decedents, so people who had died and were cases examined by the chief medical examiner, and DPSCS. And so the DPSCS data records that were included in this study were not everybody with a DPSCS record. Under the agreement of this study, it included people who were either had an arrest record, incarceration in a state prison, or community supervision, so parole or probation, if that person had an offense code related to either a drug offense or a property offense. So, you know, I think that there's further work to be done looking at the larger population of people who were DPSCS involved, but this was a really important first step for the work. Each of the agencies provided identified records, so to CRISP, and CRISP used an algorithm to perform data linkage. They have something called the master patient index. And then those records were de-identified and sent to Johns Hopkins for our analysis. I could give a whole different presentation about the legal intricacies of doing this. It was a big effort. A lot of logistics went into this. But I think at the end of the day, we ended up with a really exciting database that allowed us to understand a lot more about overdose risk here in Maryland. Next slide, please. So I'm just going to run through 3 findings from this study as they relate to people who are justice involved. And the first finding, which should not come as a surprise to anyone on this call, is that overdose risk is much, much higher among people who have touched the justice system. So the graph that I'm showing you here just shows you a fatal overdose rate per 100,000 individuals. And if you look at it from top to bottom, at the very top is the average overdose rate in the population in Maryland, about 6 million people. And you can see that, you know, it's the smallest bar on the chart, even though if you looked at Maryland in comparison to all 50 states, Maryland would be in the top 10. And then what we do is we look at conditional on having a record with different service systems. What is your overdose risk going to look like? So, you know, we know that people who are prescribed opioids have a somewhat higher overdose risk, and that's what our study showed. People who went to hospitals had overdose risks that were higher. But what you really start to see in our study is that the groups where overdose risk starts to spike are people who connected to the justice system. And we look at that across various configurations. And one of the interesting things that our study showed is actually that people who had a combination of encounters with hospitals and criminal justice had the highest overdose risk. So if you look down at the very bottom of this chart, you can see people who were inpatients in the hospital and had a record of an arrest or were on parole. Those were really the groups that had staggeringly high overdose risk in Maryland. So thinking about how people interact not just with the justice system, but also with different kinds of clinical systems can tell us a lot about their overdose risk. Next slide, please. So we also looked at different subgroups of people within the justice system. As I said, you know, we could see whether someone was justice involved because they had an arrest, whether they were released from prison, probation and parole, a drug misdemeanor, and actually a drug felony. And the interesting thing about drug felony is that actually that was a group with a somewhat lower than average overdose risk. We actually think that that might have to do with the fact that some people with drug felonies are people involved in selling drugs and not necessarily using drugs. But the group that had far and away the highest overdose risk for both fatal and non-fatal overdose risk were those people who were released from prison. And I think that's very consistent with what the literature from other states tells us. So that release from a carceral setting really is a key opportunity for changing people's trajectories, providing them with a more positive path toward treatment and reducing their overdose risk. Next slide, please. The third kind of highlighted finding here is that medications for opioid use disorders, what you might call MAT, after release is highly protective against overdose. This was already highlighted earlier by Dr. Jones, and I just want to emphasize this as being very, very true in our own state of Maryland. So one somewhat unfortunate thing is that justice-referred people in treatment are much less likely in Maryland to have medication use. So we found in 2015 to 2016 that about 42% of justice-referred people to treatment used MOUD compared to 79% of non-justice referred. I do want to emphasize that Maryland's rates are higher than other states, so we're doing a better job, but there's a lot of room for improvement here in terms of getting more people who are justice referred to treatment to use medications after their time in a jail or prison. And we also found this really, really protective effect of using medications for opioid use disorder on overdose risk. The odds ratio here was 0.41. That is actually higher than what we've even found in clinical trials comparing medication-free treatment to treatment with medication. So there's really no ambiguity scientifically about the value of these medications. The evidence is clear. The National Academies of Science, Engineering, and Medicine in 2019 released a report called Medications for Opioid Use Disorder Save Lives. The reason they gave it that title is they wanted to emphasize the life-saving benefits of medications. And one of the other things that the National Academies established in that report is that medication should be provided whether or not there is availability of counseling. So the medications are really the key intervention for providing people with that overdose reducing intervention. Next slide, please. So with all of this in mind, I just want to say that providing medications for opioid use disorder in corrections is a population strategy for overdose reduction. What I mean by that is it's not just a strategy for reducing overdose risk among justice-involved people, although that is absolutely true. It's a statewide strategy for making sure that we get the overdose deaths down for everyone. There's evidence from the state of Rhode Island that when that state provided all 3 medications in their detention, that they actually were able to cut overdose rates in the state. They found a 2/3 reduction in overdose. My team has been doing some simulation modeling, and we found that we would expect similar numbers in other states. Some interesting data out of Massachusetts showing the touch points of people who are overdose decedents, people who die from an overdose, that the criminal legal system is a key place where they are often found. And some important clinical trials that are underway that are funded by the National Institute on Drug Abuse JCOIN initiative that are really testing the evidence of different strategies for providing medications in carceral settings, including some interesting trials happening here in Maryland. Another presentation that I could have given today stems from some qualitative research that my team is doing, where we've been conducting interviews with jurisdictions that either are considering providing MOUD in their jails or prisons, or are actually going ahead and doing that. Some of you may have talked to our team in the context of that study. And what we found is customization is everything. And I'm sure that the latter half of today's retreat will really emphasize the different kinds of strategies that are needed in different places. So there's a lot of, I don't want to minimize the challenge ahead of us. I think this is a really complicated logistical, cultural, funding, everything kind of challenge, but there are many different models across the country of how to provide comprehensive medication treatment programs in jails and prisons. Next slide, please. So this brings me to the opportunities in Maryland. Of course, House Bill 116 is the opportunity that we're all gathered here to talk about. I really just want to be a champion for data and data analysis. I think that there's some really great ways to try to bring administrative data into our study of what's happening in House Bill 116 to create a culture of learning so that we can continually monitor what's happening in the system and use that evidence to inform jurisdictions that are coming online with their programs. Let's try to look at some health endpoints, measure the overdose reductions that might occur in Maryland, as we hope. This can be certainly supported by the Chapter 211 legislation. I've been in contact with the state about Johns Hopkins supporting the state in this work. We're really excited to be a partner on the implementation of the state law that requires continuing data linkage. I think that could be the chassis for HB116 evaluation, so these two state laws could work hand in hand. And I also think that there's some opportunities for the state to take advantage of new federal opportunities, including the SUPPORT Act demonstration, which allows for potentially more Medicaid reimbursement of services for people with opioid use disorder in the 30 days before release. So I hope that the state looks carefully at the opportunities for using SUPPORT Act demonstration resources. I think Maryland should lead the nation in this. We should be at the forefront. There's a lot that is happening in our region, and I think that there's a lot that Maryland could do to show the feasibility of working with different local detention facilities to provide customized models of MOUD provision. So I will get off my soapbox in just a minute. Next slide, please. And just to say thank you. This is my contact information. I welcome your questions, and I think I've left maybe a few minutes, I hope, for any burning questions from the audience.
Thank you, Dr. Salinger. And yes, at this time, if you have any questions, please feel free to raise your hand or type them into the chat box. Okay, Dr. Jones.
Thank you so much. And thank you, Brendan, for your presentation. It was wonderful. And one of the earlier slides where you were looking at the increased risk for overdose death based upon various characteristics and the involvement with the criminal justice system, was there a window of time that you were looking at, or was that lifetime in engagement with the criminal justice system?
Yeah, what a great question. So timing is everything, and that particular study doesn't really highlight the issue of time. What I think you had mentioned in your presentation is that 2 weeks post-release is known to be a critical window of time. So in another study, which I had mentioned later on in the deck about release from prison, we do find that there's a protective effect that is greatest in Maryland in that post-release time period. But there's actually, that's a durable effect. So it actually, it's not just about helping people in that first 2 weeks or that first month. We can continue to kind of help people. And the whole philosophy around medication treatment is that we keep people in medication treatment as long as it's beneficial to them. So for many people, that's going to be several weeks or months. And if people come back into jails and prisons, that's a time when we can maintain them and not stop them in their medication treatment.
Thank you.
Thanks.
Ian Seacott typed a question. Are there other states that have taken a similar approach in terms of mandating that all detention centers provide MAT?
Most of the states that are doing this are states with unified detention. So Rhode Island is the example that a lot of people talk about. The challenge in a state like Maryland is that all the localities have to figure this out in their own way. The only state that really comes close is Massachusetts, which has a pilot demonstration that's legislatively mandated, where 7 of the 14 Massachusetts counties are required to create programs. So Massachusetts is a little closer, but Maryland is really leading the nation in this.
Hi, Dr. Salinger. This is Dr. Flaherty. I wanted to ask you a couple things. I appreciate your approach. What are some of the things that you're doing, initiatives to decrease the stigma that is related with treating individuals? And second, what are some of the initiatives you've done to educate people to really understand that OUD is really on the cellular, molecular level? It's not a conscious choice. So what are some of the initiatives that you're taking? Because I know these are barriers that have been long outstanding, and we really need to overcome them in order to be able to really improve that access and get that continuity of care. Thank you.
Yeah, thanks for that question. I mean, I think the one thing that our team has learned is that the greatest way to reduce stigma is to just start treating people. And I think that other jurisdictions have learned that there is a culture change that needs to happen, but that culture change happens as we start seeing the benefits of people getting treatment and starting to have a more normalized experience. One of the things that we've learned in the criminal legal space is that one of the most persuasive things to the people working on the front lines on the detention side, on the security side, is that when people are treated in a carceral setting, they often are much easier to manage because they're not in active withdrawal. So there's a safety case to be made for the officers to having people in treatment. And then just in terms of educating the medical staff and creating a common understanding, you know, there's some jurisdictions that I think have done a really good job of accomplishing that culture change. I look at the Philadelphia prison, which is actually a jail for Philadelphia County, which I think is one of the models we should all be looking at, because they are doing this stuff at scale. They are really treating lots of people, and they are providing information to their staff to help them learn about how to do this. And they have stigma reducing videos that they show in the detention facility. So there's a whole curriculum that can go along with this, but the main thing is culture change happens as the intervention starts to be shown to be effective in the setting.
Thank you. And I'm sure that happens over time as we gradually kind of integrate all that.
Yeah.
Thank you. The Cecil County Administrator commented that they started to phase in MAT in January, and it's going very well.
Oh, I've talked, hi Cecil County, I'm really thrilled to know that. Thanks for that update.
Are there any other questions for Dr. Salinger? Okay, well, great. That was a terrific presentation. Thank you so much for your time today. We appreciate it.
Thanks. I'm here for you, Maryland. I'm really excited to work with you guys on this. Thanks.
Thank you. Okay, next up, we're very happy to have the National Governors Association and the American Correctional Association to walk us through their recently released roadmap for expanding medications to treat opioid use disorder in correctional settings. And on behalf of the NGA, we have Kaylin Hill, who is a Senior Policy Analyst, and representing the American Correctional Association, we have Elizabeth Gondels, Kathleen Maurer, and Michael Miskell. So I will turn it over to you at this time.
Great, thank you so much. Hi, everyone. My name is Kaylin Hill again, and oh, there we go. Okay. Well, thanks. Good morning, everyone. Really great to be with you all this morning, and really great that you all are having us. It's really encouraging and exciting for us to see this learning model, this collaborative within your state, you know, coming together to share your lessons learned and challenges and opportunities in this effort. I think is, as others have mentioned, a real model and a great effort that'll we think will be a good model for other states to look to as well. As Marianne mentioned, last week, the NGA and ACA, in partnership with the Centers for Disease Control and Prevention, jointly released a roadmap on providing medications for opioid use disorder treatment in correctional settings. So today we just want to provide you with an overview of that roadmap and hope to leave some time for questions at the end for any discussion. So if others haven't seen it, I'm happy to drop a link to the roadmap in the chat box here as well. But our hope for this conversation is just to note some opportunities and challenges for you to consider that we've been seeing and hearing, you know, across other states, and highlight some examples and lessons learned. This roadmap is a culmination of years of joint work between NGA and ACA, so we're really grateful to continue our partnership on this essential topic. So before we get going, I'm just going to turn it over to my partners at the ACA, led by Dr. Gondels for intro. Dr.
Thank you, Kaylin. Greetings, everyone, and we want to thank you for inviting us to present at the National Governors Association and the American Correctional Association's roadmap on expanding access to medications for opioid use disorders in correctional and community settings. But before I get started, I'd just like to introduce the ACA's Office of Correctional Health team that will be presenting here this morning. Mike Miskell, who is the Director of the Office of Correctional Health, and Dr. Kathleen Maurer, Chair of the American Correctional Association's Opioid Use Disorders Committee, and subject matter expert. Along with myself, I'm the Senior Director of the Office of Correctional Health, Professional Development in the Office of International Initiatives. ACA and NGA are very excited about the launch of the roadmap publication. And as Kaylin pointed out, it is a culmination of several years of joint work by NGA and ACA in many jurisdictions across the country. We in the corrections field recognized, as well as public health and CDC, in order to reduce overdose deaths in the United States, our jails, prisons, and community corrections across the nation, we need to play a critical role in this effort. Over the past 6 years, the ACA has been at the forefront of addressing this critical public health crisis affecting the justice-involved population. Several years ago, ACA's leadership called on corrections to develop and implement an integrated treatment program for opioid use disorders. After several years of work on educating the corrections field on the importance of medications for opioid use disorders, ACA passed a resolution on this in 2017, and in January 2018 incorporated as the association's resolution became a public policy, and it has been revised every year since 2020. This public policy can be found on the ACA website. A little bit about the policy. It supports the use of evidence-based practices for the treatment of opioid use disorders. ACA has developed recommendations specific to the needs of the correctional policymakers and healthcare professionals. These recommendations will enable correctional administrators and others, such as our jails and prisons and community corrections, to provide these evidence-based care to those in their custody or under their supervision that has this disease. With that said, we believe the roadmap will be an excellent guideline for governors, corrections administrators, sheriffs, jail administrators, and community partners to expand or start a medication for opioid use disorders program in correctional facilities and community corrections. ACA and NGA will continue this strong partnership by working closely together, assisting states and counties addressing this national epidemic. And with that, I'd like to turn it back to Kaylin.
Great, thanks, Betty. And we can go to the next slide, please. So yeah, as Betty mentioned, for individuals with opioid use disorder, and has been already discussed this morning, providing medications for opioid treatment inside correctional facilities and ensuring continued access to these medications upon reentry has been studied with discernible impact on key issues such as overdose deaths, recidivism, and opioid use post-incarceration. So while there has been a lot of progress in addressing overdose deaths nationally, we've all seen the more recent official and unofficial data on overdoses, which suggests that there's a lot more work left to be done, especially among people at risk for overdose who may face increasing challenges and access to community-based services. So that's a key part of why we've kind of came together to put out this roadmap, and hope that it shares some great lessons learned and that can be continued to use as a conversation. So that, Betty, any more thoughts before we go ahead and dive into the roadmap?
Yes, thank you, Kaylin. I'd just like to add that the roadmap provides education, and we can't get enough of education, which is so crucial to all the stakeholders. This is critical in expanding an effective program to treat opioid use disorders. And this roadmap is an excellent source of information to assist our counties and our states and community partners in expanding treatment. It is a roadmap that unifies all of us in how to expand this treatment for opioid use disorders. And education once again is crucial to this. For example, on page 9 of the roadmap, we discuss compounding challenges with increases in opioid deaths. We talk about several challenges in our counties and states that are facing the resurgence of stimulant drugs, fentanyl, and poly substances use, and how in the last year we are facing new challenges brought on by COVID-19. And according to CDC, the impact of the COVID-19 pandemic and the opioid use epidemic suggests an acceleration of overdoses during the pandemic. This disruption of daily life due to COVID-19 pandemic has hit those with substance use disorders hard. And in the roadmap, we discuss these critical challenges. We have come a long way in the last several years through education and implementing medications for opioid use disorders, but education of the field is critical, and education is paying off as more and more we are seeing our jails and prisons and community corrections implementing medication for our OUD programs. So this roadmap is a timely publication that can be used as a guideline to assist our counties and states. With that, I would like now to turn it over to Kaylin to kick off the overview of the roadmap.
Great, thanks. And we can go to the next slide. You can advance, I think, one more than that. So you may be asking, what is a roadmap? We view roadmaps as a policy development document tool developed for governors, offices, and senior state officials to use as a playbook for developing policies and initiatives within your own state. So another way to think about it is a menu of policy options or strategies that you may think about in informing your own unique approach to piloting or scaling up MOUD options in your system. And I should note, while this roadmap is geared towards governors and senior state officials, one of the key themes that we've heard from states in their efforts is that there are many ways that states and local jurisdictions can collaborate and work together to expand access to opioid treatment. So not just within state facilities, but as Betty noted, within jails to ensure continuity of care and to ensure continuity of care upon individuals for release. So we also wanted to highlight some of those partnerships and efforts as well, and a lot of these strategies that we'll highlight here today are also can be used for you all at the local level. So we can go to the next slide, and I'll turn it over to Dr. Maurer.
Thanks, Kaylin. Can everyone hear me? Yes? This is a pretty busy slide, and it's pretty complicated, and I'm going to leave the details to you to look at when you look at the roadmap itself. But I want to kind of give a handful of key themes from this slide that I want you all to be thinking about when you're putting together your OUD program. And the first is, this is not rocket science. This is basic healthcare. So what we're asking you to do, and what you guys will all realize, is this is just enhancing the care that you're providing to your inmate patients anyway. You just add a piece of this that has actually been non-existent for correctional patients for years until recently. So that's the first thing. And so we use the medical model. We use evidence-based. We use 3 medicines for patients. We give patients the options. We speak to the patients and make decisions in connection with the patients, so that when a patient helps to choose what medicine they want to be on, they're much more committed and empowered to being on that medicine. So basically, evidence-based medicine is what we're talking about here. The second key theme here is collaboration. These programs, to be effective, we must collaborate. And I think of collaboration in 2 ways. Internally, so the security or custody side of the house has to be on board with this. They have to champion this, as well as the medical side. That is collaboration internally. Externally, we need community providers. You have a community provider on today on this this learning collaborative, I'm thrilled to see that because those folks are critical. The third thing is education. We talked about education from the perspective of starting to address stigma. That is an extremely important role for education, as well as education for your prescribers and your custody folks. People are not, physicians, PAs, APRNs typically are not trained in doing this. So these folks need education, and there are all kinds of sources for this education. The fourth theme from this slide is money. You cannot do this without money. You have a remarkable state. The state is providing resources. I'm like jealous, to be honest with you. That's thrilling. And the fifth thing is, don't forget to evaluate your programs when you build them. You have to have something to brag about when you're operating these programs, so people see that you're making changes in human beings' lives. And if you're evaluating your program and it's not working the way you want it to, that gives you an opportunity to fix that, to make changes early on so you can make things happen better. So just remember those 5 themes. This is a medical model, and we use evidence-based treatment. We need collaboration. Education is key. Funding is critical, and you have to evaluate. Next slide. Next person. I think this is Betty.
Having a little technical difficulties, but I'm here. Thank you, Dr. Maurer. And as you can see on slide 6 here, identifying the common barriers, and I think Dr. Maurer outlined some of those barriers quite well. And garnering buy-in from correctional staff is critical to having an effective treatment program, as well as treatment people, because we find we find across the country that stigma still exists. And it's just not on the security side of the house, it's also on the treatment side of the house and in the communities. And also, let's talk a little bit about the addressing security and diversion issues. That importance for training, the importance of protocols and processing and having a policy and training on all of this. And the structure of our healthcare treatment and the delivery in correctional facilities. As you know, in correctional facilities, it can vary on services of delivery from state to state, from counties to counties, from counties within states. It varies. So it's very important that we educate and that we make sure that we have effective policies and understanding how we can incorporate this medical model within our current health services delivery systems. And the contracting challenges with internal and external treatment providers. I think Dr. Maurer outlined that. It is very important. A lot of when we're getting ready to reenter our patients back to the community, finding these providers is critical. And unfortunately, that stigma comes in. Some of them don't want to take our population. So those are challenges, along with drug pricing and ensuring that the continuity of the treatment post-release is smooth, that there's no gaps in the delivery of treating our patients. And securing sustainable funding, and that has been an issue, so we can have that continuity of care. And also the funds that we do have to leverage them effectively, and also making sure that we train our healthcare providers in corrections for screening processes, and sometimes we have a failure to identify co-occurring disorders and substance use disorders. So that is important. Those are some of the barriers that we found nationally that have been challenges for us in corrections. So at this point, I would like to turn it back to Mike to talk about lessons learned.
Thank you, Dr. Gondels. Next slide, please. So many of these solutions came from information that we learned from states and local agencies throughout the development of the roadmap. The document contains examples from states related to what's working for them. Whether it's funding options or how agencies have formed multi-department committees to help implement programs in corrections, this roadmap is chock full of great resources. We also received a lot of feedback during regional workshops with 14 states that were conducted over the past 2 years. Now, these states were all at different stages of implementation or the number of medications that they were providing in the same way with their local detention facilities. But what those workshops taught us is that the answers are there, and this can happen. It's just up to you, your various branches of governments, and other key stakeholders to identify where the resources are located and how agencies can align what they're doing to help benefit one another. A lot of education needs to take place along the way, but the roadmap lays out the importance of communicating with the right groups to find out who can help answer the questions to eliminate barriers. And now Kaylin's going to take us through the major themes that are found in the roadmap itself.
Great, thanks, Mike. Next slide, please. So as Mike noted, that we've been talking to a number of states that are at varying stages in their efforts. So we've seen that success in these efforts can be achieved by bringing together the key entities and officials that intersect on these issues. So that includes corrections, community corrections and reentry, public health, behavioral health, Medicaid, and health and other criminal justice agencies and actors. So these actors must be at the table to create comprehensive MOUD policies that have sustained effects. In our discussions with states, we also identified, we've heard that they've defined success in this area as providing MOUD and quality medical treatment during incarceration, ensuring successful reentry with warm handoffs, reducing recidivism, decreasing overdoses and hospitalizations, decreasing infectious disease, and increasing connections to care and services within the community. So in outlining different strategies and approaches throughout the document, we follow the general policy-making process. So we'll walk through gathering key players, developing an action plan, building capacity, and implementing and evaluating such policies, programs, and practices. So we'll just briefly walk through each of those and highlight some of the key points. So I'll turn it back to Dr. Maurer.
Thank you, Kaylin. Next slide, please. So I want to talk about the fact that these are not one-person programs. These programs require more exchange and collaboration than probably anything else in the correctional world. And that's both a good thing and a bad thing. It's a good thing when you put the teams together and they're working. It's quite remarkable how these work. Now you need to look at, first of all, you need to take some time to see who in your community is relevant to this effort. Number one, internally, your own public officials, the head of your facility, state officials. There are many state officials on this call right now. There are also many county officials on this call. That is, a lot of this work has already been done. These people have already been identified. You folks have already identified them, and getting them together into a core team is a key element. There may be some education needed for this team. If that's the case, then go either provide it, buy it, whatever. But these folks need to be educated about the whole issue of opioid use treatment, opioid use disorder, and so forth. But once people are educated and they understand the issues, including the issues of overdose prevention that we've already talked about, then there's so much empowerment and so much initiative to build these programs. It's really very thrilling. You will find, I think, when you identify these key people, and not just internal people, but community providers, I cannot emphasize that enough, The community will make this program or not, because the community will give you access to treatment on the outside. And it's fine. It's very important for us to either start people on medication or continue their medications inside the facilities. But if you look at all the data that's been generated and all the reports and studies, if we cannot maintain patients in the community once they leave our system, then our work is not effective. So get people on the inside, public officials, and community leaders and community providers, OTPs, OBOTs, office-based opioid treatment folks, they are all critical to this team, and the team needs to be built and to move forward. And my last point on this is I have found that if the team can stay together and there could be, say, a county-wide direction sort of oversight team for these programs, that is kind of the gold standard of what can be done. So the key folks are very important. Can't do this without them. Next, Kaylin is going to talk a little bit about the action plan.
Great, next slide. Yeah, Dr. Maurer makes a great point about, the importance of the community and ensuring those connections and bringing the folks together. And once you gather the key players, state and local officials can develop, comprehensive and evidence-informed plans and approaches to reducing overdose deaths and improving outcomes. A part of that planning process will include conducting an environmental scan of existing programs and policies. And that includes, the effort that you all are embarking on today with, sharing from the jurisdictions that have already been engaging in this work and seeing what can be used as models in your own jurisdictions, identifying gaps and opportunities, determining information and data needs, and then setting goals that you will run at. And then the other key piece in the policy development process is capacity, which Dr. Maurer, I think you're going to touch on that.
Thanks, Kaylin. So before you start to build capacity, you have to figure out what you already have. Could you change the next slide, please? So in order to find out what you have to figure out, you have to really look at your system from the perspective of what I need to run an effective MOUD program, and then identify the resources you have and the gaps. For example, most providers may not be X-waivered to write for buprenorphine. So you may need to do training for your medical providers. You may decide to do a methadone program in your system, and that requires licensing and all kinds of things, policies, procedures, and so forth, direct contact with the DEA, that sort of thing. So to some extent, looking for the resource gaps that you have is built out of an understanding of where you want to go, what medications you want to use, and in what percentages, and then go forward with identifying the kinds of support that you're going to need to make this program work. This is nuts and bolts stuff. This is feet on the ground stuff. This is making these, every patient getting treated in a timely manner for their his or her opioid use disorder. And then the other piece that you have to look at is what kind of state laws, regulations, and other things might you have to deal with to build your program inside your facility. I think that legislation, the 116, Bill 116, is a remarkable piece of legislation, and it gives you folks the authority to move forward with this and some funding. So that is really quite thrilling and very helpful in this setting. Okay, thank you very much. And we're going to move on now to Michael, talking about implementation and evaluation.
Thank you, Dr. Maurer. Next slide, please. So the implementation and evaluation phase is the final element to success and it's really key to maintaining sustainability. Many have found that outreach and inclusion of local detention facilities is extremely beneficial, which makes sense because that's where confinement begins. So it's perfect that you all are participating on the call today, because why not continue treatment from the community or initiate treatment as soon as possible? Starting with a pilot program is common practice and can help work out any kinks before moving towards full implementation. But you should also be learning from your colleagues in other counties. Piloting offers a perfect opportunity to evaluate successes and failures. But we all know you've got to continually evaluate all programs from as many aspects as you possibly can. And Dr. Saloner, being a champion earlier on the value of using data, we echo his same sentiment. This roadmap gives a range of ideas for process, outcome, and impact data to help increase sustainability of these programs. But you should also be sharing aggregate information or outcome metrics and process data with your colleagues from other counties as well to work collaboratively to see what's working and what needs improvement. So with that, I'll turn it back over to Dr. Maurer for information on the different models for providing treatment.
Next slide, thanks. Thank you, Michael. So there are a number of different models. The fundamental understanding that we have to have is that we need to be able to provide all three evidence-based FDA-approved medications. But within that understanding, there are a lot of different ways you can go about doing that. There is an OTP model, the Opioid Treatment Program model. This is a fully licensed, basically fully DEA licensed and SAMHSA approved and certified model that for methadone dispensing within facilities. There are some places across the country that have done this. I personally have been involved with one in a facility, and it works very well, but it has certain regulatory requirements that can be quite onerous if you're a small system. But also, opiate treatment program providers are frequently very willing to contract with facilities to either bring medicines in on a daily basis to dose patients or to run their own licensed facilities within the jail or detention center. So for methadone, there are lots of options. Buprenorphine, there are even more options. Buprenorphine is requires an X waiver, a DEA waiver on prescribers or providers, physicians, PAs, and so forth licenses, which is generally requires didactic training and then passing an exam. It's not that difficult to get a group of providers or an individual provider X waivered, and that gives you the option or the opportunity to provide buprenorphine treatment within your facilities. With your own contracted or hired staff. I do want to say that there are limits to the numbers of patients that X-waivered people can have at any given time on buprenorphine, but those limits increase over time. And in general, it has not been a barrier to treating patients. And then there are combinations and hybrids of these various options, contracting out, treating from the inside. Some of this just depends on what's available to you, what kind of resources you have internally, and what your community offers in terms of potential assistance through contracts and so forth. Now we're going to go on to Michael to speak a little bit more about these models.
Thank you. Next slide, please. So you see these different examples here, and Dr. Maurer could definitely speak more to her own experience in Connecticut and now Vermont if folks have additional questions here in a few minutes, because Connecticut was also a pioneer for implementing these programs, starting with bringing OTP providers in from the community before they started their own OTP in one of their facilities. Their neighbors in Rhode Island are also models, as we previously heard, that are now being followed as, they were early adopters of providing all three FDA-approved medications, and Vermont is the same thing. As previously was also mentioned, Connecticut, Rhode Island, and Vermont are all unified systems meaning that their departments of corrections and are responsible for the prisons and jails. So you see Iowa and North Dakota as model examples as well. Be sure to notice that it takes contacting community providers and getting those MOUs or MOAs or whatever contracts in place to really get traction for these programs. Not surprisingly, the thing we've found with many programs is that not only is outreach and partnership with local detention critical, but all levels should be leveraging the opportunities with state and local partner agencies and community providers. So making those connections and actually knowing what's available in local communities is essential. That means that state correctional agencies and local detention has to work together. Model examples of that collaboration are states like Louisiana or Indiana, Washington, and many others that have taken the time to continue outreaching with the local jails to educate and help identify resources to make appropriate connections. Because you all play an integral role to continuing or initiating treatment to keep people alive and on the path to rehabilitation. But we also know that can take dollars, which can be an obstacle at times. So Kaylin's going to take us through a couple of different funding streams to keep in mind.
Great, thanks, Mike. And I know that we're about up on time, so I'll just be brief with these two final things. So on the next slide, we just noted some other potential federal funding streams. I know we talked, it's great, the support that the state is providing and that you all have. We've also seen from a number of states and jurisdictions seeing success in sustaining programs by developing strategies to braid state and federal funds. So just wanted to highlight some of those funding programs here. And then on the next slide, we just wanted to also highlight and recognize, the climate that we're in right now. We know that this has been a really challenging year with ongoing hurdles, considering the COVID-19 pandemic that has particularly been felt within correctional facilities, and know that you all are dealing with a lot this year, and implementing new initiatives or scaling up an initiative in the midst of a pandemic may seem a bit overwhelming. So we did just highlight here and in the roadmap further on page 36 or 37, I believe, just some other considerations and things that we've heard from a number of states, just to in making changes to treatment protocols, considering potentials for shortened release time periods, although knowing that within the jail setting that you all deal with those challenges every day. But so just wanted to highlight those two things as well, and we're happy to take any questions here, or if we're up on time, we're happy to follow up with folks after as well. But thank you all so much for the opportunity.
Thank you so much. That was really informative. It looks like we have Tammy Lowy, who raised her hand a few slides back. So I don't know, Tammy, if your question was addressed or if you want to chime in.
Sorry, that was by accident. I had my powers out, so I just switched to my phone and I must have accidentally hit it.
Okay, no worries. And then Dr. Ingvild Olsen said, Dr. Maurer, perhaps it's worth adding that OTPs can also dispense buprenorphine without patient limits.
Yes, absolutely. That's a good point. They usually have to dispense it in the same way that they dispense methadone, i.e. the patient has to come every day to the clinic, but that is a very important point. And thank you for making pointing that out.
Vicki Walters commented that she loved how you highlighted the importance of partnerships with community-based programs for ongoing care post-release. And are there any models where that is working really well that you can share with the group?
So I'll take that first, at least. I think that community, reentry is always a challenge for any patient leaving our facilities. And with MAT programs or MOUD programs, patients have to be able to access care in the community immediately. There aren't 3 days. I mean, we do give bridge scripts for buprenorphine, but for a methadone patient going out into the community, they have to be in the community and treated the day they leave. There's so much risk for these folks. So we need to make sure, number one, that we begin reentry planning from the very beginning of their incarceration. I'm really a strong believer in that. I do think that the Vermont hub and spoke system has been quite remarkable. The Vermont release pattern is from every facility is linked to a hub, which is an OTP, an opiate treatment program provider. And the patients who are on methadone or buprenorphine are released generally to the care for those hubs initially, and then they might go, when they leave their community supervision period, they may go to a different hub. But that at least gives a link and a knowledge to patients about where to go. It has built a lot of care in the community. The capacity in the community for many areas is a problem for patients coming out. And the Vermont hub and spoke system, which is a whole group of office-based treaters that have started treating, and then a smaller group of OTPs that kind of provide the oversight for that group. And that, I think, is a system that we should look at more thoughtfully about expanding through the country.
I agree with Dr. Maurer on that point. I think that hub and spoke model really works, and it is scalable. And it could be a great benefit to many different states. I also think, again, that making sure that you've taken a good inventory of those community resources, but also making those different options available to not only the agencies, but to the individual to know what they can be looking for as well. I think Virginia and also Pennsylvania have a very interactive website that is very user-friendly and can help identify what resources are available as far as what different medications or what regions that people are providing care.
Thank you. Howard Ashkin is asking if you would be willing to provide your contact information to the group.
Sure, I don't have a problem with that.
Thank you. And then Sharon Lewis commented that they host a yearly sequential intercept model conference, and they highlight gaps in treatment across the justice system. And so this would be something that they would highlight within one of their intercepts.
Great, and could they send me an invitation to their conference? That would be wonderful.
Yeah, thank you. And then are there any final questions?
This is Dr. Maurer again. Can I just make one thing, statement that I forgot? Every state has a SOTA, a state opioid treatment authority. The SOTA is critical. The SOTA interacts with all of the OTPs, probably most of the buprenorphine prescribers. Have that SOTA's phone number on your ready dial, because the SOTA can help address barriers, make all the difference in the world. So don't forget about the SOTA, the State Opioid Treatment Authority.
Great. And Ann Seacott was commenting that that's Frank Dyson at the Behavioral Health Administration. Thank you. Okay, if there are no final questions, again, thank you so much for coming to present this really important information.
Hi, this is Stephanie House. I'm sorry, I had my hand raised, but I'm not sure if this is the appropriate place to ask this question, but I will. I'm on the call with our detention center deputy director, and we have been collaborating for the past 3 years, providing buprenorphine in our detention center. And we've been doing that through SAMHSA funding, and also SAMHSA funding through our Behavioral Health Administration SOAR dollars. The SAMHSA federal dollars end in September, but a lot of the work around stigma and working together, made great progress on that. We've been doing this project now for 3 years. Don't want to lose the momentum. So obviously we're looking at funding, and then also, we're looking at adding the methadone piece. And one of the things that we're looking for is whether there's any resources out there on how to look at what costs might be to add such a program, so that we can get a really good idea about what we're looking at as we try to continue our buprenorphine program, as well as add methadone.
Yeah, so I think the first thing to do, so you have to decide how you want to do it, right? You have to decide if you want to contract with the outside providers. And methadone is generally not an expensive medication. So you need, if it were me, and I have actually done this in my life, I would call the providers and work with them to see if they can, how much they would charge to bring methadone in, if that's what you would choose to do. The other piece, building your own OTP internally, that's a little bit more complicated at the start, a little more expensive at the start. After you get that up and running, it's just a matter of meeting all the regulations, but it works really well to have the methadone available when you need it, and your own skilled people who are prepared to dispense it. I'm happy to speak with you if you'd like. You can give Stephanie, you can get my contact information, but there's a pathway that you can go down to determine which is the best option for you and how to go about getting there.
Thank you. That would be terrific. And of course, also looking at the support piece as well, because we know how important that is, in addition to the medication. Thank you very much.
Mm-hmm.
Give us a start. Appreciate it.
Sure.
Thank you. And so in the interest of time, I think I'm going to have to move on to the next presenter, but Howard Ashkin did share the MATOD searchable OTP directory, and then Ann Seacott shared that MATOD is the State Association for OTPs, and they're happy to identify community-based programs to work with the local detention centers. So thank you. Thank you so much for joining us, and yeah, we will be following up with more questions.
Thank you so much.
Great.
Thank you.
And so at this time, I'm actually going to hand it over to Ann to just talk about the spirit of House Bill 116. She was one of the advocates that helped push this and get this signed with the legislature. So Ann, please take it away.
Great, thank you.
We cannot hear you, Ann. Sorry.
Just give me 1 second.
Okay, you're very low, so I don't know if it's a volume issue. I think Ann's going to be calling in. So while Ann calls in, are there any final questions for the NGA?
I have a question. It's Eric Weintraub. Where are we as far as having Medicaid pay for in-jail services? I mean, there's been some talk about that. I'll drop off and listen to the answer.
So Dr. Weintraub, your question was around where are we with Medicaid paying for?
Yeah, I've heard nationally that there's been some push to reimburse for some of these services. We've talked about sustainable funding.
Mm-hmm.
So I'm just curious if there is being a move towards that happening. Is it something we might expect, or is it something we shouldn't count? Well, obviously we won't count on it, but just where we are with that nationally.
I'm not sure. Is there anyone on the line that can speak to that? And it looks like Anne is on the phone. So if anyone can quickly answer Dr. Weintraub, and then we'll move on to Anne.
Yeah, this is Kaylin from NGA. I know that we've seen a number of states, submitting different waivers to support initiatives, prior to release and during the reentry planning and transitional planning phase. So that's something that we're certainly keeping track of, and that, see what the movement and momentum is. But currently, at the moment, to my understanding, there's no, but I don't know if anyone else on the ACA side has any thoughts on that. Oh, Mike, I think you're on mute.
Thank you. I know that there are a number of states that have put in for different waivers, 1115s or the 1915B, but those are still in the process. But we're hopeful that we have traction on that soon.
Thank you. Are those waivers specific for MOUD or just treatment in general?
I know that one of the main ones that's cited a lot is the Kentucky waiver, what they submitted, which I think is for treatment more broadly. But I think that it would include MOUD, but we can follow up on that. We're hoping to also keep tracking it and can share any information that we hear out of that. Oh, and yeah, someone highlighted the Support Act as well.
I would also say that the Medicaid Reentry Act is in the current legislation that's being considered in Congress. I understand that it may actually be threatened. And so I don't know if the NGA has any thoughts in terms of kind of continuing to support the inclusion of the Medicaid Reentry Act in that piece of legislation.
That's a good flag, and I'll have to loop back with my health colleagues on that. But I know that that's something that that NGA is actively working on, and it's something that a number of governors support. So yeah, I can definitely get back to you guys on that.
Great, thank you. So I'll turn it back to Anne. We still cannot hear you. If you're on your phone, you might need to hit *6.
Okay, how about now?
Yep, we can hear you. Thank you.
Oh, thank goodness. All right, I should learn all these months into virtualness that Google Meets does not like my microphone. So good morning, everyone. Thank you for your patience. I'm Ann Seacott. I'm a partner with the government relations firm, Public Policy Partners. One of my longtime clients is the Maryland chapter of the National Council on Alcoholism and Drug Dependence. And they were the lead advocacy, one of the lead advocacy organizations behind House Bill 116. Based on the presentation we just saw, I think we should all be very proud of where Maryland is on this topic and acknowledge that while we've got a ways to go, we are clearly ahead of the curve. So I think that's great. And I think a lot of that information that we just heard was really helpful. The goal of House Bill 116 was actually quite simple. It had to do, the question was, how can we prevent people from dying? We saw all of the horrific numbers that have been described throughout these presentations of people leaving incarceration and overdosing on opioids. We knew that in all of the policy work that had been going on, you all were aware of, the kinds of legislation, the kinds of funding the governor was putting in, all of the attention being paid to this. It became clear that there was a segment of people that we were leaving out. So we decided to try to figure out a way to address this growing problem. The solution in and of itself wasn't difficult to come up with. Treat the illness that's leading to people dying. But our correctional system is not built to prioritize people's health needs. We need, so we started the conversation with lawmakers and correctional administrators about what it would take to provide medication-assisted treatment for people with opioid use disorders. We found examples, leaders in the field, where MAT was already being used to one degree or another. So we knew it was possible. We also knew that the operational side of making it happen would be a legitimate difficulty. But the biggest hurdle at the start was convincing correctional administrators that the benefits were well worth making these changes and these investments. As past speakers have mentioned, we needed a culture change, and we need and still need to break down stigma, both with regard to people who use drugs, who have opioid use disorders or any substance use disorder, as well as the medications used in the treatment of opioid use disorders. That we just needed also to convince everybody that this was going to help externally in terms of overdoses when people leave, but also internally. And I believe that was also referenced by an earlier speaker. In trying to get everyone on board, we decided to bring stakeholders together. Some of you here on this webinar were with me on the 4th floor of the House office building, hashing out the details of a bill. Advocates wanted to respect the operational challenges this presented at the local level. And we very purposefully made sure, and this again harkens back to what we just heard from the national perspective, that we built in enough flexibility in the statute to allow locals to work within their own means with their local health departments, with community-based treatment programs in their own regions to decide what would work best. Clinicians wanted to make sure we were setting up best medical practices. And correctional facilities wanted to make sure their concerns were heard, especially with regard to the cost of implementation. We knew we couldn't accomplish everything all at once, which is why we're in the midst of this phased-in approach. We ended up not being able to get the state correctional system to be part of the law, but of course we hope we're able to demonstrate the success and bring the state facilities on board before too long. I'm really pleased there are so many representatives from State Department of Corrections here on this call today. Ms. Hill in the last presentation mentioned continuity of care. And that's one of the things that gives me a sense of urgency around how we do the implementation of this whole effort. We know that as people move between local detention centers and between local and state facilities, that the more uniformity we have in terms of people being able to access and continue to receive medications, the better that's going to be for the individuals and the better it's going to be for the system as a whole. There have been successes and setbacks, and that's what, I think a lot of the people that follow me are going to be talking about. I think this is really important to be able to talk about the lessons learned. I remembered one of my very first conversations with Jack Kavanaugh from Howard County. And we agreed that the best way that we were going to make progress was for correctional administrators to talk to and learn from each other. I know you all have been doing that for the past couple of years, and I'm very happy to see this event taking place today, and the way that it also certainly includes local health departments and local behavioral health authorities. I thank the leaders in the communities who stepped out there really and got the ball rolling with this. The folks we'll hear from a little bit later from Howard County, Montgomery, Prince George's, and St. Mary's County. We think that their ability to step out there and start giving this a try and essentially be a pilot for the rest of the state, we're all very grateful for that, and we hope to continue to build on all of this. I think Maryland should be very proud of the work that we've done, and I agree with one of the earlier speakers, Dr. Salinger, that Maryland should continue to be in the lead in the nation in this effort. It's why I asked him the question about, has any other state taken this approach? I really do think we should embrace the leadership position we have in this, so I thank all of you who are involved in this, from the governor's office, the health department, and everybody that's been involved, and remain helpful, willing to be helpful in any way possible, from the advocacy sort of policy side of things, as well as in trying to help make connections with community-based providers as well.
Thank you, Anne, and we really appreciate your time today. We know that you're very busy with session, but thanks for sticking with us, even though we're a little bit behind schedule at this point. So are there any questions for Anne before she hops off? Great. Hearing none, at this time, we're going to offer a 10-minute break so that everyone can get up, stretch their legs, and then come back for our 4 county presentations. So we will see everyone back at 11 a.m.
Good morning, everybody. This is Darren McGregor from the Behavioral Health Administration, and I'd like to welcome you back. I'm going to have some technical difficulties here with my camera. Great. So we'll give it I guess one more minute to let everybody get back on. We still have a lot to discuss. This morning pre-break was information rich and much appreciated. I really thank all the speakers who have joined us for the first part of this call. So for the second part of the call, Jim Hedrick and I will be welcoming the 4 jurisdictions that have launched this pilot program. And what we'd like to do is to have each jurisdiction make their presentation. And then after each jurisdiction, after all the jurisdictions present, then we'll sort of open it up for questions, and then the jurisdictions can sort of be a panel and help field some of these questions about the challenges and successes and the implementation of having an MAT program in the detention center. So as it is 11:02 by my clock, I think we should begin soon, or right away. Jim, did you want to say anything before we press on?
No, I don't believe so. Just that excellent presentations, and it was mentioned that one of the important things is for the areas to have a pilot program, and the 17, 18, 19 jurisdictions that have not implemented yet. This is fantastic because we're going to now hear from 4 pilot programs. So I think this is great. Thank you all.
And yes, I agree. This will be excellent. So according to the agenda, we're looking at Prince George's County, Montgomery County, Howard County, and St. Mary's County. I know that there have been some issues with power outages, and I hope everyone will be able to stay on this call. So let me invite Prince George's County to make their presentation. And if you would be kind enough to introduce yourself. Thank you.
Good morning. I'm Director Karen LeBay of Prince George's County Department of Corrections, and I will ask my staff to introduce themselves.
Good morning again. I'm Guy Merritt. I'm the Acting Deputy Director for the Bureau of Administration.
And good morning, I'm Gregory Bairstop. I'm the Acting Chief of Inmate Services in the Department of Corrections. Okay, I think that's it.
Is Dr. Meske not on?
Dr. Meske?
She's not. I thought she was on earlier. Okay. Good morning. I'll just give a little introduction, and then I'll let Division Chief Greg Bairstop talk about the program. And if Dr. Meske does come on, have her talk as well, because she's the medical provider to our program and has been involved since its inception. I just wanted to let you know that Prince George's County piloted its MATS program in March of 2019. And during that March and April time, those 2 months we saw 24 individuals were screened, and at least 42% were administratively discharged because they had an early release, but all of them had received Suboxone. We used the CALS screening to identify opioid users, as well as our medical providers' mental health screening tool. In the first year, the program experienced a high turnover rate due to the average length of stay for the participant. As a result, our therapeutic treatment program within the jail, it was difficult for them to actually get participants to be available for the treatment or to stay during the whole therapeutic treatment process. So we then reevaluated what could we do to do the treatment component that was necessary for individuals who are opioid users to be able to be successful, particularly when they get released in the community. And we implemented what is known as the expert model. And so that was one of the things. And another thing we realized is that when the inmates were released, there was a need for, even though we would refer them to a community provider, there was a need for intensive case management. And so we found it very difficult to, even though we would refer them, we realized that it was very difficult to see if the participants would follow up, or if we could follow up and find out data on their success. So we ended up doing another component using the grant funding to actually link to a MAC community provider where we could do direct referrals to them and ensure supportive services were given. And so we realized that we definitely needed this continuity component. And this component, we started doing initial referrals in February of last year. When we did the referrals, we recognized also initially in February of last year, we referred 9 to the community provider, but however, only 50% actually appeared at the provider site. One of the things we recognized is that pandemic did for a while, particularly for us, March through April, it affected the continuity of care for the community provider. So the community provider now does what is telehealth counseling sessions. And so the participants have to participate in at least 5 counseling sessions to receive their continued prescription. One of our challenges today is bringing on board and finding peer recovery specialists. We have found that the peer recovery specialists that have been recruited and hired by the community provider was concerned about their background and concerned about coming into the facility, even though we told them and explained to them that their background will have no effect. And so recruitment and hiring of a peer recovery specialist has been difficult for us. But since the inception of our program, particularly our in-house or community program or continuity of program, the participants' preference has been Suboxone, and that's probably because of the euphoria effect, than Vivitrol. We have only had 4 participants to do Vivitrol in the entire program. And at this point, I'll let Mr. Bierstock continue.
Okay, can everyone hear me? Okay.
Yes.
All right. All right. Next slide. Okay, so this is basically what I'm going to cover in a very short time. Director LeBay gave the preface, so I'm going to talk a little bit about the SBIRG implementation in our facility, and also the different factors involved in referring detainees or clients, as we refer to them, to treatment. For those detainees that are going to remain with us and really are not going to leave rather quickly, we do provide clinical case management, and I'm going to speak on that as well. I'm going to share some statistics with you that you might find interesting, and I'm going to talk a little bit about our partners that have really been instrumental in making our program a success. Next slide. So our program really begins with the screening, and this happens at the onset when detainees are coming in or being booked into the jail. We want to reach them immediately. So as you know, when people are arrested and they come into the jail, they're processed, and our processing staff, they are the ones that first identify any substance use disorder, because they collect an array of information that they enter into our offender management program, OMS system. And in that system, they can identify if a detainee or someone coming into the jail has a substance use disorder. Part of our screening then, once they've been identified in processing, they then refer the detainee to the medical unit for screening. And Director LeBay mentioned the COWS, the tool that's used to identify whether they have an opioid use disorder. And once they have been identified as having OUD, a list is generated and is sent to our inmate services, behavioral health and wellness staff. And let me just share with you, for a lot of the jurisdictions that are trying to get the program up and running, it wasn't easy going for us in the beginning either. We did get the list, and we got it on a weekly basis, and we were trying to meet people or get into screen them, but we found that because we're primarily a pretrial jail, a lot of our detainees are cycled out, or they leave rather quickly. The average stay in our facility is 29 days, and a lot of defendants can leave within 2 or 3 days. So we were missing a lot of people, and we weren't getting that opportunity to screen them as quickly, which is what SBIRG requires. So what we did as a staff, we developed a calendar, and we assigned a staff person to every day of the week, or every day of the business week, Monday through Friday. So anytime we got the list from medical, that day, staff was there to see them. So this is within 24 hours of being booked in the jail. And that made a significant difference for us to capture people early on, screen them, get them into treatment, and save them really from the horrors of the streets and the risk of overdosing and fatality. Next slide, please. So I mentioned that immediately our staff begins to see someone for screening for a treatment, OUD or MAT treatment. Again, they're seen that day. And this is the technique that we use. We utilize motivational interviewing, and that's very important to our SBIRG program, because when we're having that one-on-one session with our client, we're exploring with them the risks of substance use behaviors. We're also needing to identify, in order to appropriately treat them and guide them, we want to identify where they are in the stages of change. So are they in pre-contemplation? Are they in contemplative? Are they in a determination stage? Are they ready to take action? Or they're in a relapse mode? Or they're sort of maintaining? Also, when we have that one-on-one session with them for the screening, we also utilize strategies for motivating clients to get them into treatment. We want to be able to elicit some change talk. So we find out from the detainee exactly what their desires are. Some may be to get their children back. Some may be to obtain employment. Some may be to obtain housing and get out of the unstable environment that they're in. Whatever it is, we take that desire and we link it with treatment. So they get a clear, direct understanding that, hey, I can get my desires met, and treatment is one of the avenues, and one of the major avenues. And then you start to see that change talk. We also assist clients to eliminate any barriers to treatment, and some of those may be what I just mentioned, but also the other barriers in terms of transportation, the need for insurance, and we work with them to obtain all of those things, IDs, things like that. Next slide, please. So referral to treatment. Again, in that one-on-one session with the detainee, we right there, then they develop a continuity of care plan, which, by the way, they walk out with, they take with them. So they know who they're being referred to. They have an address, they have contact person. They also get a guide with other community treatment providers for self-referral. Some people prefer that. We also, as the Director LeBay had mentioned, we have a direct linkage to community outpatient MAT through our medical director, Dr. Meske, who's on the call. So a lot of our clients who build rapport in the jail and know the staff, they're more likely to go into the outpatient MAT, especially because of their connection with the medical unit and Dr. Meske and her staff, as well as our connections with the like CVS for prescription refills. So we have those connections, and we have a particular pharmacy that we deal with. So that has been very instrumental in getting people to maintain that connection as they transition into the community. Now, for clients or detainees that are going to stay with us a little while, other than three or 4 days, they can also enter our jail-based substance abuse treatment program for MAT services. Also, for people who are going to remain with us, we call them our SBIR clients. They, on a weekly basis, we go and see them weekly for weekly case management, and that's our behavioral health and wellness staff that provide that. Next slide, please. Now, what's involved in case management? Again, when we're meeting with them, we're working with them to, again, develop and solidify a continuity of care plan, and also to get them to buy into it. Again, what's important for you to know, we're always utilizing motivational interviewing. So that has been really key to getting clients to follow through, to develop their plan, knowing that this is their plan, and having buy-in. So once they have that buy-in, they're more apt to implement it. We also have community service providers that we work with, not just for substance abuse, but for any other needs that they may have. We provide individual counseling because, as you know, during the COVID pandemic, there's a lot of depression, anxiety, a lot of need for skills. And right now we're doing it until we get our virtual connections in the jail. We're doing it through handouts. So we have counselors that meet with the client. They provide a handout, say on identifying your triggers. They come back the next week and they talk with the detainee, because they by now have had a chance to think about and write down their triggers. And we do a lot of exercises like that through handouts so we can keep them engaged. We also advocate for the client's needs and goals, as I mentioned earlier. Whatever their goals are, we're going to support that, and we're going to help them make the connections they need in order to get those needs met. We also, as part of that, refer to departmental programs. So within house, we have anger management we can refer detainees to. We also have programs such as, when we get it up and running, the Barber program. We have a Pentor program that's underway where we have mentors that write the detainees. We have life skills where people can learn, and again, we're doing this through handouts. They can learn to develop certain life skills that they need, communication skills that they need on the outside, how to develop resumes, and different avenues in areas that they may need, again, to reduce the risk of them coming back into the jail. Next slide, please. Sorry, next slide, please. Thank you. So now we're going to look at a little statistics. So as you can see from the graph, we want to look at the slide before. Thank you. So as you can see, the purple line indicates the number of MAT referrals that we receive through our medical unit. The green line is SBIRG. So that is the number of people we were able to screen. And again, remember we had that bumpy start in the beginning. But for the most part, we're doing quite well to being able to capture a lot more people because we're seeing them the same day. So of the number that were referred to us, 72% have been seen in terms of Esberg. Next slide. So what you're looking at here, our pie here, is that 67%, the bigger slice of the pie, has been our people that have come in and received MAT. People that have been remaining with us in the jail who receive case management, that's the 33%. So everyone is getting touch, everyone is getting that service, whether they're going to be with us for a while or they're going to leave within 24 hours. The next slide. So this gives you, these next three slides are going to give you a picture of our demographics. And what you're starting to see, this is a demographics that's going to span from 2019 up to the present moment. And so as down below, you'll see this is divided or categorized by ages. So we have age ranges 18 to 24, 25 to 44, and 45 to 64. And what you notice is that especially in 2020, last year, we're seeing a really significant use or people identifying as OUD in the age range of 25 to 44. So there's a steady increase, and I know we're early in 2021, but I think it's going to be more reflective of last year. Next slide, please. This slide, again, spanning from 2019 to 2021, identifies gender. So if you're looking at each of the 3 years, what we're seeing is that we're getting an increase in opioid use disorder among our males, and it's steadily increasing. Again, we're early on in this year, but it's probably going to be very reflective. Next slide, please. Again, this slide spanning 2019 to 21, this is looking at race. And so what's significant about this slide as you look over the years is that we're starting to see an increase in the use of opioid among Black males. So pretty much it's also increasing with white males, but significant increase among Black males. Women, a slight increase among white females, and but that's the takeaway from this row. I'm sorry. Next slide, please. This slide gives you a picture of our MAT within the facility. So as you can see, the larger slice of the pie is the Suboxone, people that were treated for Suboxone. And as the Director LeBay had mentioned, 59%, almost 60% of our population is treated on Suboxone. We also have Vivitrol. Again, we only had 4 people, and so that's only 2% of our population with Vivitrol. The 22% is people who are returning. So of that number, we do see a little bit of revolving door, probably not as much as if we didn't have this available. And then 16% of our population are released early during the MAT. Next slide, please. And again, this was stressed earlier this morning, the significance of collaborating with our partnerships. It really doesn't happen, and success is really contingent upon the role and the collaboration with our partners in the community. So we are very heavily connected with our health department. We have a very strong relationship with them. And so we do refer people to the Chevrolet Addictions Treatment Program, who provide, and they provide methadone treatment, buprenorphine, as well as Vivitrol, along with evidence-based models. And they have morning and afternoon dosing for the methadone. They also provide Narcan training, which is very important for staff. We have had Department of Corrections staff, and some of our staff have become trainers. And early on, we were going into the housing units and providing training in the housing units, Narcan training in the housing unit with detainees. And then they left with the Narcan in their property. So that was a significant part. And let me tell you, I performed some of those trainings, and just about all of the detainees that were in my trainings, just about all of them had mentioned that they had overdosed before. Some of them, it was the second and third overdose, and they were very blessed to still be with us. Another significant partner is the Bridge Center at Adams House. They're in the community to specifically help returning citizens. So these are the people who we connect with for insurance and mental health connections and treatment and sessions, and also referrals to the Department of Social Services. Also partnering providers, we have a direct link, as I mentioned, with Dr. Meske, MAT program in the community. So they go directly from the jail right into the outpatient MAT program. And again, she's they've done a marvelous job, because what we found there is that the detainees that go there, the clients that go there, they are pretty much compliant and responsive, because of number one, they want to get the prescription to continue their medicated assisted treatment, and number two, we found that they like virtual connection better than the traditional one-on-one interview. So that's been a very interesting finding. We connect with the Department of Social Services, and that is really for our people who are homeless and needs more stable living. And Community Crisis Services, they provide the warm nights, because a lot of our people, they leave the jail without a place to stay. So we don't, again, want to lose them to the streets while we're trying to get them into MAT. Next slide. All right, so this, as our moderator had mentioned, Dr. McGregor, that we're going to save questions for later on. I did want to ask if Dr. Meske wanted to add anything, or Deputy Director Merritt.
Hi, this is Meske. I'm the treating physician at Prince George Department of Correction. I'm extremely happy, to see this program going very well. We are amongst the first to join, and probably we have the highest number of patients in the jail throughout the state. And we've been taking care of patients with substance use disorders for many years, mainly by treating symptoms, symptoms of withdrawals. But having MAT has changed the way we practice medicine. I mean, as a clinician, I think it is the most rewarding and satisfying experience to take care of patients going through withdrawals by giving this effective medications, and symptoms improve significantly within hours. It's the most humane way of treating patients with substance use disorder. It has its own challenge, but overall, inside the facility, we were able to identify patients within few hours of their arrival, and with a history of substance use disorder, we will start with the protocol, the COUS protocol for opioid use disorder, and all other CWAS for alcohol withdrawals. And we admit them to our medical infirmary and start the protocol right away. And having, the counseling service, case management also is very helpful. Of course, we had our own challenge. Once they leave, the day they leave from the facility, in the past, even if you give them referral, you connect them to the program, there is no guarantee that they will get the next dose of medication as soon as they leave from us. That was the gap. But having the community MAT program that we used as a bridge service, I will give them the prescription the same day they leave. We fill their prescription, any pharmacy they take it to, so that they will have that next dose at home instead of going and looking for these medications on the street and accidentally overdosing. So I think that's the most effective program that we did, is this bridge order until we connect them very well with the community providers where their insurance can kick in and they can get the care. In the meantime, giving them prescription, making sure that it is paid for, and we do substance abuse counseling with it, case management piece of it. I think that was the most effective. And
Dr. Meske, hi, this is Darren McGregor, and I'm very sorry to interrupt, but I think your program is absolutely wonderful, and having had the opportunity to visit there, but I would like to now proceed as time is of the essence here. We're a little short on time. I think we're a little behind schedule. So
that's all. I think I'm done.
Okay, thank you, Dr. Meske.
Okay.
That was great.
Okay.
And thank you, Prince George's County, for your presentation. So now I invite Montgomery County to present their challenges and successes with their MAT program.
Okay. Good morning, colleagues. Can you hear me? Can you hear me?
Yes, we're hearing you. Yes.
Real quickly, from Montgomery County, we have a number of staff. In fact, you commented, Darren, on the number, but I know Director Angela Talley is on. I know that Warden Susie Malagari is on. Our Chief of Medical and Behavioral Health at DOCR, Department of Corrections, Robin Cody is on. And Robin and I are going to tag team this presentation. We also have Kay Beckley, the Chief of Management Services from the Department of Corrections, on this call. I believe that's everybody from Corrections. If anybody else from Corrections is on, please weigh in quickly. I don't see anything services.
Hardy, we're getting a lot of feedback. So once again, I'll remind everybody, if you're not speaking, to please keep yourself on mute, because there's a lot of feedback going on now. Thank you.
And I agree with you. I hear the feedback. It's messy, but this is much better. Thank you. On our HHS, Health and Human Services side, two of the people on are managers who report to me: Athena Morrow of the adult forensic programs, which are in the jail. And we also have Mr. Larry Stewart, who is the manager of our community-based medication-assisted treatment program and our adult drug court program. In addition, we have a number of staff on from our local behavioral health authority. They, of course, do the oversight of the funding and the oversight of making sure that we're complying locally with the mandates of this. I know that Rebecca Garcia, one of our managers, is on. I know that Yasmin Mabry, our quality assurance coordinator, who works specifically with this initiative, is on. And I believe Samar Khalif was also on. And the local behavioral health fiscal person, Aaron Fashion, was on. With all that introduction said, I'm going to move on. And again, the two principal presenters for us from Montgomery County are Robin Cody and me, and we'll kind of go back and forth. We are aware that we have roughly 15 minutes at tops. I know it's 11:35, so I'm sensitive to that. I'll own that on the front end. So in Montgomery County, this was an initiative that we signed on early on. We had seen the legislation in, I guess, 2018 and 2019 that this was coming. And one of the best things about our history in Montgomery County, the history between the Department of Correction and Rehabilitation and Health and Human Services, is that we have implemented a number of historic initiatives that highlighted behavioral health. And just to be real quick, Jail Addiction Services has operated in our local jail since about 1990. And then the Clinical Assessment and Transition Services, a program we refer to as CAT, came on board. And I want to say it was the late 90s, after there had been a number of suicides in the jail, and we needed to take action and correct that. So one of our best advantages is that long-standing collaboration between both the Department of Correction as well as the Department of Health and Human Services. In terms of this initiative, the three departments that signed on to implement this, again, are the Department of Correction and Rehabilitation, Health and Human Services, and the Sheriff's Department. Again, all three of these departments have a long-standing history of working together. The other thing I want to highlight briefly, one of the best things about our Department of Correction and Rehabilitation in Montgomery County is they have been treatment sensitive and treatment savvy for many years. Director Talley, at an earlier juncture in her career, worked for Health and Human Services. So Director Talley would be one of the best examples of what we would call a boundary spanner. And of course, now she's in the role of Director of Correction and Rehabilitation. And before she was there, actually it was Mr. Robert Green who early on was telling us that we needed to be part of this. So I do want to highlight that very briefly. Now, with all that introduction out the way, talking about our program, would you go to slide 2? So we signed on and we intended to be compliant with this to the best of our ability, effective January the 1st, 2020. And what I want to say about that real quickly is we knew that we started this with not everything running like a fine-tuned machine. It took time to get the approval letters from the state. It took time to get the money loaded in our financial systems in Montgomery County. So what we decided to do early on is to do continuations on medication. And that's where we are at this moment in time. We are not initiating at this time, and we'll say more about that as we go to other slides. Of course, the other goal and the long-range goal for us is to increase the number of folks on MAT among incarcerated individuals. Obviously, as we all know on this call, MAT is the gold standard for treating opioid use disorder at this time. Would you please move to slide 3? Slide 3, please. Okay, on this slide, Ms. Robin Cody, would you talk about the left side of the slide, and then I'll come back when you finish with the right side.
Thank you so much, Hardy. And just to give everybody a brief overview, the model that we've implemented, we've described it as a three-legged stool. One of those legs is the Department of Correction and Rehabilitation in terms of actual administration implementation of the medication. And then the other two legs of the stool reside under Health and Human Services, and Hardy will be speaking to those aspects. But I'm going to speak to the one leg of our three-legged stool, and that is the Department of Correction and Rehabilitation. And then within our department, we have 3 additional branches that all work together to make this program happen. And for us to get up and running by January 1st was a Herculean effort of a lot of people working very closely together and trying to change the wheels on the car as you're driving. We didn't know what we didn't know, but we gave it our best to have the basics in place and then grow and evolve as we understood and learned more. And so within corrections, the big piece of this for us is under detention services, under the warden's authority, the actual custody oversight. And that includes the correctional officer supervision of the patients as they participate in this program. Also, the custody and security concern of medication diversion and how to mitigate those risks within our facility. And then also there was the vulnerability for our partner, the sheriffs, because of the geographical distance that was between the jail and the MAT program in the community. And further in the presentation, we're going to talk about some of the problems that we have fixed as we've gone along. The other piece under the jail is the medical management piece, and that is my area of oversight. Areas that we had to get up to speed with quickly, making sure that our providers understood what this was and that they had the correct licensing and the X licenses to be able to prescribe and provide those bridges until our new intakes were linked with the MAT clinic. And then also getting our nurses up to staff, making sure that they understood both the administration of the medications day by day and also the accountability of the medications within the jail as controlled substances. There was also a lot of partnership with our contract pharmacy and making sure that we were able to get the right medications, that we had the correct licensing and accountability practices in place. We had to work through the DEA process to be able to keep stock MAT medications on hand. And that was an arduous process in and of itself. And then there was also a big piece of us, project collaboration and case management with our HHS partners as we all work together to oversee the care of these patients. And then the other piece internally for us was the budget oversight piece. We all went into this with a lot of unknowns about what funding was going to look like, how it spanned fiscal years. So under the direction of Chief Beckley, we had to navigate how to forecast for what our staff and budgeting needs would be, not even knowing what kind of program participation volume to expect. We also had to learn how to be in compliance with the grant management and all the associated reporting requirements across multiple fiscal years for state and federal, and also reporting requirements, partnering with HHS in terms of data that needed to be provided for the University of Maryland as part of the grant requirements. And then finally, the individual details about operational expense reconciliation, getting the right budget codes in place and making sure that expenses were identified under this particular program. Those have been the pieces of it for us over the past year. And I'll pass the baton back to Hardy, and he'll speak to the Health and Human Services side of it.
Thank you, Robin. Real quickly for Health and Human Services, again, there are 3 agencies or 3 programs principally involved with our efforts in this initiative or this pilot. The local behavioral health authority provides oversight for all of what we do. They help us make sure that we document all of the different pieces of this that we need to document. They were not involved fully from the beginning, but since they came on board, they've been a tremendous difference maker in making sure that we are adherent and compliant with all of the different documentation pieces of what we need to provide. A major player in this effort is the Jail Addiction Services Program, or JAZZ program as we call it. And of course, that's our substance use treatment component in the jail, long-standing in the jail since the early 90s. And again, one of the things we made a decision about early on was to use existing staff. So thanks to Athena Morrow and her team, the supervisory therapists, Monir Kanjani, peers that work in the adult forensic services. Specifically, we have a peer who works for our mental health court. And so he is the person who is following up with the referrals that we get for this pilot project at this point. And he's doing a wonderful job in that capacity. Of course, the MAT provider for us is the county provider, Medication Assisted Treatment Services. So again, there are 3 parts or 3 programs: local behavioral health, jail addiction services, and medication assisted treatment. Now, one of the things that we have struggled with, and I just want to highlight, our intent is to hire staff that are dedicated to this project. To date, we have 1 person, a nurse coordinator, who actually just started the latter part of January. So that position is filled, and we didn't put it on here, but we still need to recruit a therapist. We need to recruit 2 peer specialists, and we need a physician or nurse practitioner or physician assistant to be part of the team in the jail. Real quickly, once a person is identified for admission to our programming, it's the peer who sits with the person, does the screening, and invites them into treatment. The peer gathers the initial demographic data and completes the GIPRA instrument. The nursing staff and Health and Human Services gather background and prior treatment documentation. It's the MAT doctor who schedules the intake assessment. And then it's the peer who also does follow-up to encourage adherence for the participant, for the participant in the program. Would you please go to slide 4, because I know we're running out of time. So just to review, at the start, one more time, we did initiate this effective January 1 of 2020. And we didn't have a project manager who was dedicated to this, but you know, we were nimble and we did the best we could to make it work. And we're very much a work in progress. We have not totally arrived. In the beginning, it was Tony Sturgis, who was the prior chief of medical and behavioral health services, and I, who were attending the different planning meetings, a number of which occurred at the Wade Avenue location of the BHA, Behavioral Health Administration. Once again, I want to highlight that our current operation is limited to the continuations of those that are already on the various MAT medications. And so that's where we are at this time. We're going to go to the middle slide, which talks about progress made and some of the challenges that we've solved. And Robin, I'm going to want you to chime in on some of these. So
absolutely.
We've established parameters and infrastructure. I guess one example is, I know there's a meeting of the treatment team every Wednesday morning at 11, and then we have a bi-weekly meeting that is every 2 weeks dealing with bigger picture administrative issues. Our ability of navigating the funding and the expense tracking is a work in progress that is done by both Kay Beckley of DOCR and Aaron Fashion, who work closely together. Robin, would you comment on the medication management?
Yes, so I alluded to that earlier, but internally we had to navigate a lot of firsts, both in terms of getting the DEA licensing to be able to keep our own stock, methadone and Suboxone on hand when we receive new intakes, for example, on a Friday at 2 in the morning or Saturday morning, and the MAT clinic isn't open. How do we help ensure that that continuity continues until the MAT clinic opens back up on Monday morning? There was a lot behind the scenes, and continues to be, that our nurses have to do before our providers can do that bridge dosing. We verify with their treatment program, get their records. We found that there was a tremendous administrative burden. On average, a new admission took a nurse 90 minutes to do all the details needed to just do that continuation. And on a weekly basis for our medical staff, we found that just coordination with all the players averaged about 180 minutes. And then in terms of the actual daily administration of the medication, we find that it takes approximately 30 minutes at least 3 times a day to administer the meds, plus at least another 30 minutes throughout the day for our shift change counts to ensure that our controlled substance counts are always correct. Back to you, Hardy.
On the staff hiring, real quickly, that has been a challenge for us. Again, we are in the midst of trying to hire a number of contract staff on the Health and Human Services side from a vendor. That has not been easy in this COVID time period. So that it's connected to that. It's made it more challenging in terms of applicants wanting to even work in the jail, for example. In addition, again, we mentioned some turnover of strategic persons. Mr. Tony Sturgis, again, was our long-term chief of medical and behavioral health. He retired 7/1/2020. Ms. Robin Cody became the acting, and she's doing a tremendous job, and recently was confirmed as the actual final hire in that chief position. So that's a tremendous validation of what she's done, and it's helping us out a lot. The other thing on our side, Health and Human Services, we did have a turnover. We had a psychiatrist on board, and during that COVID period, he made a decision that he had some health concerns, and he did actually decide to leave us. So he was a short-term hire. We were able to bring on another doctor to serve in that capacity. And since the new doctor came on board, I will just mention it still has been connected to COVID concerns. At one point, there was concerns with him in terms of having had an exposure or having tested positive. So again, COVID is a big part of what is going on in terms of some of the challenges of operation.
Okay, go ahead.
Last but not least, on this side, we have eliminating transport security issues with telehealth, and that's connected to, we don't have to have the sheriff bringing inmates to our community-based MAP program. The last thing, just these bullets on present status, we've treated 27 to date. We still have some budgetary uncertainties because, you know, it takes time to get the confirmation of the next cycle of funding, for example. The unpredictability of transfers, the COVID challenges, unsure if virtual inductions will be permitted. Obviously, we are doing, our doc is doing virtual appointments now, but when we get to the other side of COVID, we don't know about that part. And then we hope to have a full complement of people so we can fully implement this and not only do the continuations, but initiate as well. I'm going to stop right there.
All right, Hardy and Robin, thank you so much. Thank you, Montgomery County, Director Talley, hello. And so we're going to move on to Howard County. Just to let you know, we're going to go till 12:30 so we can field some questions. So if Howard County is ready, please take it away.
Hi, we're ready. This is Howard County. I'm Andrea King-Wessels, and I'm the acting director. Director Kavanaugh, along with Dr. Ro Bonakorski, started us in medically assisted treatment back in 2016 with Vivitrol. So we had a lot of groundwork laid, and we have moved forward and along with our partners, which are pretty simple, which is WellPath, which is our medical provider, our Howard County Health Department, who does all our counseling and sets up our aftercare programs and after counseling, as well as our treatment clinic, Silverman's. That's about the 3 groups that are involved in that here. We have 3 BOA, Bureau of Addiction counselors. We have 2 peer counselors, and they are phenomenal. You can't, in my opinion, do this program without strong peer counselors that can talk to these folks about addiction. And then we have a MAT coordinator who also happens to be one of our nurses, who also happens right now to be our hospital administrator. So we're in a world where there's like 3 of us wearing 6 different hats. We also have 2 mental health professionals that are hired through WellPath that also assist us in this program. Our biggest, and I'm going to let Chris Collins, who is our coordinator for the Bureau of Addictions here at the jail. He works at both locations and coordinates his counselors here. I'm going to let him speak to the different minutia, so to speak, in the program. But overall, our biggest struggles are what everybody's are: coordination, money. We sometimes you have to be willing to spend the money of within your own budget while you're waiting for money to arrive. The reporting requirements are pretty extensive, but it's totally worth every penny spent, in my opinion. And I've been in corrections for 43 plus years. So anyway, with that, I'm going to let Chris Collins take over and speak from here.
All right, well, good morning. My name is Chris Collins. I'm the supervisor of the treatment services here within the Howard County Detention Center. I do work for the health department. As Ms. King-Wessel said, I mean, we kind of started this back in 2015-16, working with Jim Hendrick of GoCat, you know, and getting Vivitrol started here. And we've kind of expanded since then. So I think, as Ms. King-Wessel said, we had a pretty good basis and foundation to kind of start with this or continue with this, actually. Now, it doesn't mean that we haven't had a lot of you know, changes to programs and having to do things differently. And I will discuss some of the challenges at the very end of the presentation today. But with that being said, if you can change to the next slide, I'll kind of talk about our plan, our program. Next slide, please. All right, so, you know, our goal in this program is to identify individuals for MAT as quickly as possible. Now, you know, one of the things we really need to get or had to get was buy-in from everybody on the, you know, jail side of things, and also with other programs, because we never know where the referral is going to come from. So, you know, kind of the easier referrals are individuals who come into the detention center are already on MAT. They're identified by medical when they do their physical. But we may have individuals that aren't in our program that haven't been identified yet, and a correction officer may come up to me and say, hey, Chris, you know, this guy might be interested. So, you know, we do rely on those referrals from every piece of the jail system and other programs as well. So once we identify somebody, we will do a full-blown assessment. That assessment will be done to determine and to make sure that the person has an opioid use disorder, and also to make a recommendation for a level of care. So when they are released, we can set them up with whatever aftercare they meet criteria for. Counseling wise, you know, we offer group counseling, and I'll get into more detail about that shortly. We also offer individual counseling, and we also offer acupuncture. So we try to kind of do a holistic way of kind of treatment and working with these individuals. When it comes to referrals, you know, if we identify somebody through our treatment services, I will just contact medical. You know, consents are signed for us to be able to talk to medical. So even though we're all kind of housed under the same, you know, place, you know, we still have to get consent from the client to be able to communicate with medical. So we'll you know, send them that paperwork. Also, Vivitrol consents get signed as well. So that's a pretty seamless process that's worked really well for us. You know, medical will then meet with them if blood work's necessary, for example, for Vivitrol. They'll do that, and then if everything's good to go, they'll go ahead and get them started on MAT. So prior to release, for release planning, you know, we will conduct an aftercare planning session with the client. And once again, the assessment is important for this because it identifies what ASAM level treatment they meet criteria for. So we have a lot of clients who, meet criteria for inpatient treatment. So we'll set all that stuff up for them prior to their release. One of the nice things with working with Silverman's is that it's right down the street from the detention center and actually part of the health department building. And so what happens, we deal a lot with somebody gets released quickly, we don't know they're getting released, and they're on MAT. So what we can tell them is, they can, and whether we're at the office or not, they can show up to Silverman's the next day and continue with their MAT. So that's really helpful in terms of continuity of care. Next slide, please. So I'm going to go quickly through the services provided. I already talked about our counseling program that we do here. We do offer 6 groups per week once, when things are normal, which they aren't right now. They are gender specific and kind of deal with things like relapse prevention, aftercare, early recovery, et cetera, et cetera. And then we also offer the acupuncture groups once per week as well. We have peer recovery support specialists, which I know a lot of people have talked about already. We have 2 detention center peers, and then the health department actually has 8 peers. And so we utilize both. So we have peers in all of our groups. They kind of offer that different perspective, that lived experience. And so we find that really, really helpful to have them co-facilitate our groups with us. As per the screening, brief intervention, referral to treatment, I'll talk about later. I know it's been talked about already. Obviously, we have the medication services, and we can do the medications in terms of Vivitrol, methadone, Sublocade, and buprenorphine. We offer strengthening family programs. Jail staff are actually trained in that, so they can conduct those groups with family members. We offer T4C, anger management, getting ahead, and we have health department staff come into the detention center to actually do the Narcan trainings. They'll actually get doses in their property so that when they leave, they actually have the Narcan to take with them. In terms of continuity of care upon release, we work very closely with reentry. So once again, we can make all the referrals for individuals who are in our program. But once we kind of make those referrals, our role kind of stops there, and reentry kind of picks up there and can follow these individuals in the community and can help them with a lot of other things, which we'll talk about in a minute. Next slide, please. So as per screening, so those can be conducted at any time during their entrance into the detention center. So that could take place at central booking, commitment, medical classification, and it can be done by anybody. We work with Mosaic, I think, for about a year, and they helped us get our SBIRT program up and running here. So that's working really, really well. The peers mainly conduct most of the SBIRT screenings. We use the audit C and the drug questions. And so they are, some people are identified that way. And then our peers will conduct follow-up with individuals. I know it was mentioned earlier, I think through PG County, that some people are only here for a couple of days, and so they're not going to get into our treatment program at that point. So our treatment services. So at that point, it's, the peers play a big role in kind of working with them and helping them with referrals. And right now, due to COVID, we're doing a lot of things virtually. So like our assessments are done virtually. And our peers actually kind of work with us to get someone on the computer. We'll do the assessment, and then we'll follow with the peers in terms of what they need and making referrals, et cetera, et cetera. So the SBIRT's been really important in the peers as well. So there's 2 types of people we're kind of dealing with here. People who come in on medication-assisted treatment, and we will keep them on that. And I'll talk about one of the challenges about that, but we try to verify and continue them within 72 hours. So, one of the challenges is that the treating provider doesn't always get back to us. Right. You know what I mean? So we really need that to kind of continue the MAT. And then we will start people on MAT while they're here. So once again, I've already talked about the medications, and you'll see a slide, I think it's next, about that. But we can work with people to get them started prior to their release, or if someone's going out on work release and meets criteria for that, we'll get them started on that prior to their work release. Next slide, please. So I'll go through this real quickly. Unfortunately, our medical person isn't here today, but those are the 4 MAT that we do utilize: Vivitrol, Sublocade, which is the injectable form, and methadone. So as you can see, some of these things we administer here at the jail, but we have to get them started at Silverman, which is a OTP, which is once again not part of the health department, but it resides in the same health building as the health department. So we actually have to use staff and correctional officers to take them there to get them started. Next slide, please.
You want me to?
And I'll let Ms. King-Wessels take reentry.
Along with that, as you all know, in the reentry business, it's not just MAT that we got to worry about. It's also housing, jobs, identification, health insurance, along with that continuity of care, both mental health and addiction counseling. Our challenges, next slide. Go ahead.
So I'll get through these pretty quickly, but I think these are probably, what everybody wants to hear about. So some of the challenges that, we've had is space for staff, so we do have, multiple staff that are involved with the program, and there's only, so much space within the detention center to house everybody. So we kind of work with that. The hiring of the counselor, we've actually have accomplished that. We've hired our third counselor now. And what we do for MAT is anybody who comes in on MAT, we have one counselor now that we've hired the third that's assigned to that person to assess them and kind of take care of that case management. Costs, regulations, and medications, transportation and transfer. And I talked about how we have to transport some people to Silverman's to get them started on medications. The start-stop, that is where we are having someone on MAT here at the detention center, but they get transferred to another detention center that does not offer MAT services. So that's a big issue for us. Medication management, security, the watch take protocols, grant reporting. We do the SOAR grant, and that's been extremely helpful, but we've had to adjust our protocols many, many times. We have struggled with some of the GIPRAs because, once again, people are only here for maybe a day or two, and so we've really worked with the VHA and University of Maryland to kind of improve our processes to make that work a little bit better. Delays in treatment verification, talked about that already, where someone comes in on it and their provider in the community is not responding to our outreach attempts. And then, quite frankly, with COVID, and I know everybody's talked about this, it's really just thrown a wrench into really what we're doing. When it comes to medical, for example, they're focused on COVID and getting people tested, and then when people test positive, getting them quarantined, and now doing vaccination. So it has limited what we've been able to do since COVID started. So right now we've had to kind of stop, for the lack of a better word, starting people on MAT because we don't have the staff to kind of transport, the medical staff to take care of that. We are keeping people on their MAT who come in on it, but that should change, obviously, when things calm down with COVID to kind of get back to normal again. But it really has thrown, kind of wrecked a lot of what we were doing here, during that time. So that's it. I think that's the last slide, or next slide.
That's it.
All right, that was it. Well, thank you very much.
Okay, well, thank you so much for that. Very expedient presentation, great information, challenges, and so it is now 12:08, and I would like St. Mary's to be able to come up and if they're ready to talk about their program at all. I would also like to leave some time for questions, and St. Mary's has very graciously yielded a lot of their time so that we could do this. So Marianne and Tammy, thank you so much for that. But is there anything you'd like to just put out there before we go into the question and answer period?
The main thing is was really larger jails that took and talked about their programs. Our experience is very similar to that. And I'll just put the offer out there. We started with the flow chart of the legislation. So if anybody would like our flow chart of the legislation and any of our policies and procedures, please let us know, and we'll gladly share. So that's the main thing.
Great, thank you for that. And yes, I guess we'll get our contact information out to this group. And so, because the primary reason was really to have the other detention centers hear from the local detention centers that are actually doing this program and really understanding what it takes to implement such an MAT program, and not just MAT, but MAT under House Bill 116. So we've talked a lot about MAT, but House Bill 116 also includes mental health, peer support, and case management. And so that'll be a discussion for another day, I guess. So I'm going over to the chat box here, and so Howard Ashkin has asked Prince George's County Detention Center, how is the County Detention Center partnering with the county's OTP? Prince George's?
Okay. So, as Dr. Meskey had mentioned, Dr. Meskey had funding that she was able to develop the OTP, outpatient treatment program. And like I said, we have a direct link with them because she's actually in the jail. And when she refers someone, she refers to her staff. She's hired staff, but also, and I hope because of the direct linkage, people coming out, the detainees coming out, they already have the rapport, and so they already know the staff, and therefore, when they're going out through having a prescription, they're able to fill that prescription and get the counseling. The counseling again is virtual through the we work with mainly sessions through the telephone. That's what they're comfortable with. But I think that is probably the correct way that we can do it. I don't know if I answered the question or not.
I think you did. This is Director LeBay. I think you did a good job. I think the key for us with which has been a success for us in Prince George's County is one that our medical provider is in-house. And that has been successful. And then as Greg said, Dr. Meskey, who is the medical director and actually oversees the MAT program, one of the things she recognized was the importance of giving the participant a prescription, and when they go out into the community, they're able to fill it. So when we link with our community provider that we identified with, they're able to also fill that prescription as well immediately for the inmate. And I think I answered it right. I don't know if Dr. Meskey is still on the phone, but I think she's just rejoined. She could answer the question as well.
Yeah, this is Meskey. It was kicking me out repeatedly. And do you want me to comment, or is there anything, any question?
You can comment on how we're linking people to OTP in the community.
Yes, for patients who came to us and who are already in MAT program, the best thing is to reconnect them to their own program where everything is set up for them. But for those who relapsed and recently were not in a program or have never been in a program, we take care of them as bridge service, where we will give them prescription the day they leave, and we fill in with the program. The community MAT program will pay for the medications, and we will continue with substance abuse counseling and case management, and until we successfully reconnect them to long-term programs in the community, they can stay with us. Some of them, it might take up to 3 months, and we never drop them from the bridge program until they're successfully, reconnected. So the whole point is that by that time frame, not to have any gap from the time they leave the facility until the next dose of their medication.
Wonderful, thank you. So, Vicki Walters asks, with respect to Sublocade, injectable form of buprenorphine, this is to Howard County, could you speak to the benefits and challenges of that?
Yeah, so some of the benefits is that it's a once-a-month shot, so it's not as labor-intensive as having to take someone back and forth to Silverman's or up to medical. There's no diversion risk really, you know, in terms of people, you know, cheeking things or whatever, and then taking it back to the units and all that. I think once again, our medical person's not here, but from talking with her, I think it's an extremely expensive shot. So I think that's really the negative of that. But other than that, I think it's a really good option, and we've had pretty good success with it. So yeah, so I think those are the positives and negatives of using SUBLOCADE.
And we did a cost analysis and realized that although it seems like a bigger dollar item, it's really not when you add up the cost of the strips and then the counting and control and all that. We found it is not as expensive as it appears.
All right, thank you. Thank you so much. Moving down the list, just let you know that Shantae Hunt, who is our project director for the SOAR program, just wanted to thank all the jurisdictions. All of you are participating in the SOAR program, and she just wanted to shout out and say hello and thank you. So there's a question from Lisa for Howard County. Lisa Flaherty.
Yes, hi, real quick. If you could just give me like a rough estimate or percentage of the number of individuals that you had to transfer to another detention center or facility that did not offer MAT, and then that was a barrier and noted relapse. I don't even know if you've collected that data, but I'm just curious. Thank you.
It wasn't a lot because we often made the decision not to put people on MAT if they were going to a facility that we knew that did not offer it. Then we got to the point where we would try to call ahead and see if they could maintain it for us if we started someone on it. But I don't know, I want to say, you know, we realized that was really kind of cruel if we started them on it and then they didn't offer it where they were going. So like for GOC, we didn't put anybody on it. But if we thought that another county that was trying to get up and running or could accommodate this one person and it would benefit them, we would try that.
Okay, thank you.
And this is
thank you.
For Montgomery County, we had similar scenarios, but they, in every instance, wherever they were transferring, it was to a facility either out of state or somewhere that did have an MAT program, and we, coordinated on that. We do have some current participants that are anticipating eventual transfer to facilities that do not. So the time will come for us where we may potentially have to wean somebody off once we know their status.
Okay, thanks, because that represents a challenge in and of itself.
Correct.
Yeah.
Thank you. So if you haven't looked into the chat box, please do. Marianne Thompson from St. Mary's has listed her email and emphasizing her offer that if you're interested in looking at any of the policy and procedures, they are willing to share that with you. So just send her an email if that's of interest to you. Thank you, Marianne. And then from Latanya Stallworth, GPSCS. So for the 4 detention centers, what is your partnership with the Division of Parole and Probation for those individuals who are released and are on community supervision? For continuity of care purposes, are the aftercare plans shared with DPP agents?
We, as a part of our case management, contact their parole agent and make sure that they understand their aftercare needs and the program plan that we've developed so that we work with them.
Okay.
For Montgomery County, what I would say on this question, we work very closely with our local Division of Parole and Probation. in terms of the management of offenders who have active probation, at the time that they are detained in the local facility. The great challenge on this is that obviously, in terms of being the treatment provider, we do have to respect 42 CFR and HIPAA regulations. So, I mean, the standard thing would be that you hopefully the offender will sign cooperatively, and indeed most do, if that's the case. But again, I would say generally in Montgomery County, we do work very well with our local division of parole and probation. But on this specific question, for me, the question is whether the offender is going to sign the release, because it's a standard release of information for any type of relationship for somebody who's in a treatment program.
Thank you.
And
similarly,
our counselors who go to the medical unit to conduct the SBIRG, again, within that 24-hour window, we do have a close relationship with the public defense, probation. And being that they are licensed, all our staff are licensed, they understand the parameters around confidentiality. But once they sign that consent, we do, especially we sign the consent so that we can share the continuity of care plan, because it's very important that the probation officer, everyone is on board and is aware, because they can help, and I hate to use the word, because it's really not enforce, but it's more influence and motivate in terms of the continuity of care plan.
Thank you. Anything else, Marianne?
In St. Mary's, that's a very valid point, because we work very closely. We have a standing meeting with parole and probation. Every 2 weeks, we do a conference call. And to be quite honest, I had not thought of adding the MAT to that discussion. So it was a very good point. So I learned too. So thank you very much.
You're welcome. I see that Mr. Woodson is listening intently to these responses. Neil, I hope everything is good.
Yes, good afternoon, and everything is well. And that was a great question from Latanya Storworth. And I appreciate the fact that the different local detention centers do cooperate and collaborate with the Division of Parole and Probation. And I do know firsthand a lot of you do, because our director is always informing us in our management meetings, of the collaboration that we're trying to accomplish with the local detention centers. So thank you all, appreciate it, and a wonderful, wonderful conference here. Appreciate that also.
Good to see you again. So we have time for like one more question before we have to make our closing remarks. And from Menard Brooks, would any facility like to comment on barriers, i.e. diversion, drug pricing, and securing sustainable funding?
My understanding is that the funding for this program, I mean, we get sub-grants, there's different grants, but my understanding is that the state has made the commitment to the different facilities to assist with the money, because it would not be sustainable if each county had to fund this, especially at this time.
And I can speak to that as a DHA representative that, so according to House Bill 116, the Department of Public Safety and Correctional Services and the Maryland Department of Health has been tasked with applying for federal funding to help support House Bill 116. And so we are going into our third year of funding about 9 detention centers on different levels for a MAT program. So as Dr. Jones mentioned earlier, and I don't have the numbers on the top of my head, but so we are moving into a no-cost extension That money has to be spent by September 29th. And then there's SOAR 2, year 1. And we're hoping to see some carryover to continue these programs. So yes, we're going to have to get to a point where we're going to have to identify more funding. And to Dr. Weitraub's question earlier, I mean, we can only hope that some of this will be connected with Medicaid. So.
And if you'd like, I'd speak on the medication diversion. Medication diversion is a problem in all our detention centers, and it's something that we carefully watch. But it definitely is an issue. And what we have found is if we had somebody that was on Suboxone and they diverted their medication, then we steer them towards the Vivitrol, and we have partnered with Friends Research, so they go in the Friends Research study, so that helps that. And as far as drug pricing, that's all in the formulary that we have with our pharmacy contract. So that's where we do the drug pricing at, through the pharmacy contract.
All right, thank you. So with only 4 minutes to go, Marianne, Jim, any final thoughts or comments? And certainly from my side, I thank all of you for your participation. It was a really good turnout. There was about 129 people here at one point. So thank you for taking the time.
Yeah, I'd just like to also offer that, really appreciate everyone's presentations and all the cooperation and all the work that was done on this. I think it's very appropriate that some of the last comments were related to re-entry, which is stated right in the bill that is a major part, where there is emphasis on that. And I see 1 or 2 comments also in the chat room that groups are getting ready to hopefully, let us know on some of the what they're going to do. Please don't hesitate to contact us. We really need to get the next 6 going, jurisdictions going. But we want to help out in any way, and please contact us. So. Thank you all very much. Really appreciate it. Marianne?
And I just wanted to thank everybody for their time. And if anybody wants to reach out to any of the pilot programs, we gladly entertain questions. And as always, Darren and Jim Hedrick have always been such a great partner with us. And so we truly appreciate them.
Thank you. You're welcome.
Thank you very much. Thank you.
And I'll just echo what Jim and Darren said. Thank you all for your time and attention during today's conference. I think it was a really great learning opportunity, and we look forward to continuing the conversation and continuing to expand services. So with that, thank you, and have a great rest of your afternoon.
Special shout out to Marianne Gibson. I mean, she did a fantastic job of identifying speakers and planning this, and you can see why she's the director of planning. And the title not to be taken lightly. She did a great job, and I thank you for it.
Thank you. I appreciate that.
Absolutely. I second that.
Thank you, everyone. Have a great afternoon.
Okay, take care, everybody.
Thank you.
Bye-bye.
Bye. Thank you. Wonderful presentation.
You're welcome. Take care.